Hello, everyone, and welcome to the last session of the advanced course in biomedical imaging. This course, as you know, is organized by the Faculty of Medicine of the University of Coimbra in collaboration with the UT Austin Portugal Program. My name is Mara, and together with Vera, we'll be representing the UT Austin program and giving technical support to today's session. Since it is our last session and in the name of the program, I would like to thank all of you for your interest in the course. We really hope that you've had a productive time throughout these past weeks and were able to learn more about the topics we've discussed. Today's session will be completely in English and we have a full agenda. I also take the opportunity to thank our speakers for today, Professor Falk, Poenisch, Thomas Whitaker, João Seco, Joana Dias, Stefaan, Tavernier, and Célia Fernandes. Thank you for your availability. I will now give the floor to our moderators for today, Professor Margarida Abrantes and Professor Salomé Pires. Wish you all a great session.
Thank you, Mara. So welcome everyone to our last session of this course. For those who followed us for the majority of all the sessions, we hope you enjoyed and learned a lot during this journey over several techniques applied to biomedical imaging. For those who joined us today, we also hope you enjoy and take the most profit possible of our session on proton therapy. As Mara already said, today we will also have the opportunity to know more about the 3 projects on the medical physics area supported by the UT Austin Portugal program, and I would like to remember that the UT Austin Portugal program is highly committed in supporting this type of projects, in supporting the advanced training of oncology radiology experts, and one of the initiatives they do is this the launch of these calls for projects. So you will hear about 3 of them today. So now let's start our proton therapy session by introducing Professor Falk Poenisch. Professor Falk is Associate Professor at the Department of Radiation Physics, Division of Radiation Oncology at the University of Texas, MEDAC. He finished his PhD in 2003 in experimental physics, in which he explored the quality assurance of the delivery of carbon ion therapy using in-beam PET. This project required both experimental measurements and Monte Carlo simulations. Since 2009, he has developed expertise in proton therapy that will be the main topic of our session today. First as a proton fellow and now as a faculty member. While he spent most of his time as a clinical physicist, he also worked on several projects related to proton therapy, including quality assurance and the impact of protons on pacemakers. His strong background in research and clinical applications of radiation therapy using different kinds of radiations and particles gave us the honor of having him today talking about principles and practices of proton therapy. Professor Falk, thank you again for accepting our invitation, and the floor is yours.
Thank you, Dr. Pires, for the nice introduction. I will talk about the principle and practice of proton therapy. That's the title of the talk. So it's an introduction in proton therapy. So I will start why proton therapy. Then I will go on to the hardware, the system itself. Then I will describe the different delivery methods that we utilize here. And then I will go over a general radiation treatment planning workflow, because maybe some people are not familiar with how the radiation treatment is conducted. Then I will also mention the uncertainty associated with proton therapy, and then I will show the different delivery methods, namely the passive scattering and the scanning beam planning. So why proton therapy? Long time ago, Robert Wilson suggested that the use of proton therapy is beneficial because it has a low entrance dose. Oops, that is not good. I'm not sure whether you see my cursor, but do you see? Has a low entrance dose. and then has the highest dose in the depth. Compared to this for X-ray, it has a fall off like this. So the highest dose is not in the tumor. But of course, this is a stylized situation. But so that's not, the tumor doesn't look like this. Another benefit of proton therapy that's unique to it is that there's no dose whatsoever on the distal end of the peak. So the conclusion was it can treat deep-seating tumor, and it spares the OARs that are in front of the tumor and distal to it. And with that, one could increase the dose. So as I said, the tumor is not that narrow as indicated, and so this is a paper from our department when we opened our Proton Center in 2006. So in order to create an extended SOPP, also called spread out Bragg peak, we need to superimpose pristine Bragg peaks at a certain weight. So the distal one has the highest weight, and then the weight changes. And if you're combining this well, including the spacing, then you're getting a flat SOPP. Or it is always the goal of treating the tumor or a structure that you determine as tumor with a flat dose. That's the concept of radiation therapy. And so in order to achieve this, we can use physical devices, or you can use the synchrotron to vary the energy. So this I come to this later at a later point. So this is a schematic drawing also from this publication regarding our layout from our system. The layout overall is similar if you have a multi-room system. So big institutions have this because they have the need for multiple rooms. There is also from IBA now an option of have a single room system, or Meviant has this as well. And so, but the general outline for a multi-room system looks like this. So you have an accelerator. In our case, that is the synchrotron. That consists of a linear accelerator that accelerates the proton, in our case, to 7 MeV. Then the protons go into circle, and then are bended. This the red icon are the Mending magnet, and then they are steered in the individual rooms. Here, gantry 1, gantry 2, gantry 3, and then we have a fixed beam line as well. So we have in total 4 beam lines that we use for patient treatment. And here another sketch, technical drawing. So one thing I want to point out, so this is a very detailed drawing. I want to say that overall, oops, my bad, this is PDC2. But what I was going to say was, on this end, they are identical, visually identical. So the difference between passive and scanning beam is very, very minimal. It's just some accessories inside the nozzle at the very end that makes a difference. And apart from one device here. Therefore, overall, the step from here to here is not so big, but on the software requirement and on the delivery was not so easy. Therefore, we were the first system in the US that had a scanning beam available, and so this was in room 3, and since scanning beam has superior characteristic over passive scattering, therefore for our PTC2 beamline, we will have this available. And PTC2 beamline is just another building, 100 meters away from us. And it utilizes the same concept. So you have the accelerator here, and then you have these 4 rooms, this time 4 gantries. You see the footprint of the room is slightly different because this has to hold CT on rails. But other than that, this portion is the same. You notice this thing doesn't have a maze. So this is new to us. And so we have a shielding door. So what the characteristic of this one is, it has versus PTC1 from this from the big picture is it has a compact synchrotron. So the radius is smaller, therefore also the room is smaller, and therefore the poured concrete needed to support the entire building is much less. As I said already, we don't have a maze, so also less concrete here. So we have all 4 rooms on matched scanning beams, so they should come out the same beam properties, and we have seen in other centers that that can be achieved. In 2 rooms with CT on rails, all 4 rooms have cone beam CT, all 4 rooms have RT-RT system developed by the Hokkaido. And then we have at least 2 rooms set for surface imaging. We will have probably more. We need to get familiar with the system and then decide of whether this is good for us and what are the applications for it. So here, this is the schematic again. Now I'm confusing you a bit. I'm back to PTC1. So what only thing I wanted to point out here is all these little icons here is a device. So you have a lot of device. So if you follow this path, the beam has to go to all these devices, and all devices do something to the beam. And so it's really so they need to work together in order to get the proper beam at the right position and the proper quality. At the same time, another thing you can see here is only one person can use the beam at any time. So it means that means it's not good. So, but of course, if I don't have beam, then it's not good. There's some safety mechanism here that prevent the beam to going in, and so when they are blocked, then no beam is coming in. So what I was going to say is the only one person can use the room, which means if this room is using it, then the other one aren't allowed. And so there is always, or there's a potential weight between the rooms, in between the fields. And I come to this maybe at a later point. So that's different to if you have a single room accelerator. And all the Linux or Photon Linux are a single room accelerator. So this is again the Linux. So this in our case, this is again it's a most a picture from PTC1. However, the Linux for PTC2 will look alike. It's the same manufacturers, the same similar model. So it's quite long overall. I know I don't have a scale for this, but that's probably a very the longest structure even for PTC2. And so it consists of 2 stages. It's important. Other people have only 1 stage. We have 2. And what it does is it increases the current. So this one is actually a picture from the back. So here it's where the protons are injected, and the gas is injector is not the right word. The gas is flowed into it, and then the current is applied to the first stage, and then comes the second stage here in the back. Yeah. So after these are accelerated, that piece that I just showed you come here from the opposite view, comes in here, then it makes a little swing here, and then it goes into the synchrotron, where the proton has to rotate. Oh, I'm not moving. Has to rotate hundreds and thousands of times to get to the right energy. So the acceleration only happens at one location, and I think it's this one here. And then all this other stuff is to focusing and to control the location to keep the proton in a circle. So they only accelerate every time they go here, and then incrementally increasing energy. But since they do it so often, they have then the proper energy. In this case, it's between 72 and 222 MeV. Well, that system is different to cyclotron, where you have a fixed energy. The concept, of course, is kind of similar because you have also a circle where you accelerate the proton, but in the case of the cyclotron, you can only deliver 250 MeV. Here, we can deliver any energy between 72 and 222. However, to make the tuning easy, we have 94 energies. And then, in order to get the proton out of the wing and don't keep them there forever, there is this, it's called an RF kicker. So it applies a radio frequency, and that will knock out a bunch of proton, not many, out of this out of their beam path. They're actually separating the beam path, and because of this, they're going towards the radiation transport area, and this is shown here. And then there are other magnets as shown that brings the beam then into the room, or better to say, into the gantry. So you can see here, this is a gantry here, a person for scale. And this is a picture from our original PTC-1 device in Japan. So they had it pre-assembled, then they disassembled them, and then they ship it to us. So, so it's just some specs. So this is a 190-ton device. The radius is it's a little bit misleading. The radius is 260 centimeter. So this is the distance from here to here. This diameter is 5.50 meters, and the inner diameter and outer diameter is 13 meters. The rotation speed is required from our government. Cannot be exceed 1 RPM, so 1 revolution per minute. So it takes 60 seconds to go from here all the way to here. Well, you cannot travel this, but from here all the way to here. The position accuracy is better than half a degree, which it is, which we found over many years. There are counterweights here on the back end to make this rotating smoothly. The isocenter accuracy, mechanical isocenter accuracy, is 1 millimeter diameter over a 360-degree rotation. So this is how it looks in the inside, so official Hitachi picture. That is indeed probably done before the first patient was treated at PTC-1. It doesn't look that yellow, so don't get nervous about this. It looks better than this. But the concept is here. You have this, we call it the snout. This is our table, and then we have a moving floor which provides the therapist with access, so they can step into the room, can work on the patient and set up the patient, and so can step on the floor. Otherwise, they would fall into the gantry, so that would not be good. So good. Of course, tool can also fall into the gantry. We don't want to have that either, but it happens. So beam delivery methods. So there are two types. One is let's call it the old-fashioned, the standard passive scattering. This requires the beam to spread it laterally and to modify the range, and to collimate, and then also collimate distally. But those are all things needs to be happening with different devices in order to have a decent quality beam. Active scanning is the other one, also called pencil beam scanning. The pencil is, however, at PTC1 rather big. It's more like thumb beam scanning, so this is the size of a thumb. So that's what we have, and we using at PTC1 as an equivalent to IMRT step and shoot, which means we deliver a spot, we turn the beam off, we deliver again, and the time interval between is in the millisecond. So it's, you won't notice the stop, but it's actually happening. So the beam doesn't stay on. So in between the spots, it determines whether the mu were delivered correctly as planned. If it deviates from the plan, then the accelerator will stop. So back to passive scattering, so this is a nice drawing from Dr. Goitin. So they had so what it's needed to do this. So the first thing is this, they call it range shifter wheels. So we call it range modulator wheel because it's actually not shifting, if you want to see it as well. Yes, there are steps here, and those are highlighted here. And indeed, there are 6 steps here, and that's what we have too. And but on top of this, for us, we have active delivery on passive scattering in regard to turning on and off the beam. But I may come to this later. But important, since we are having a so-called double scattering system, we have a first scatterer and a second scatterer. So with the help of this, we can get a uniform dose profile. So we're starting out with a very sharp pencil beam here, then it's widened here, and then it's further widened here. And while it's going further in the projection, now you have a rather large field that has a uniform dose. So that's the point, though, is in passive scattering, in order to make the field collimation and have the dose flat, you're wasting a lot of proton. That's important because that also has implication of neutron production. You're not wasting protons, so you cannot produce neutron as a secondary unwanted particles that can travel very far everywhere, including the patient. So the outer field dose is higher, and so that's also one of the benefit actually from the double scattering versus single scattering. If you have a single scattering as the people had at MGH, the scatterer would need to be much bigger, and as a result of this, this cone would be much wider, and so you would lose even more protons than we do. Then, in order to collimate, as I said before, the field collimation is done here on the we call this apertures. And then here comes a compensator that shapes the beam distally, right? So this has different thicknesses, but I come to this as well later. So again, to the first scatterer, then to produce this profile, then you have this and this is stylized. In reality, it doesn't look like this, but if you do this, combining this two, then you're getting a flat dose. So what we have is the RMW for range modulator wheel in order to create our spread out break peaks. So this is an example here. Let me step back a second. So we have 24 RMWs for each room. 24 because we have 8 energies and 3 field sizes. So the number of energies per RMW could be also different, but we decided in the design phase that we wanted to have 8 energies, and that produces this many options. And we also wanted to have 3 field sizes. So all of this was aimed towards minimizing the neutron dose versus previous existing machines. So our neutron dose is really, really low compared to other machines, but also even lower to some of the VMAT photon plant with high energies. So that's pretty impressive considering Proton can produce a lot of neutrons. And this is all for pulsar scattering because that was the state of the art at the time, almost 20 years ago. So therefore, um, um, that's how it was done. So the RMW itself is made of aluminum, and then it has it can also make out of ABS plastic. It rotates at 400 RPM. We have 6 modulation, and so per rotation that results in 40 modulation per second. And so you can, if you, and on top of this, we turn on and off the beam, and so by doing so, we're getting a flat profile. You see this here again. So I need to move on a little bit. So again, the devices on W, then we have the aperture, 3 field sizes, as I mentioned. Each sheet comes at 2 cm thick, so to make them not too heavy, we typically use 2 to 3 pieces per patient. So make it between 4 cm and 6 cm thick. Then we have this acrylic compensator. We created a smooth surface machining method. The thickness can be anywhere between 2 cm and 15 cm. So what do compensator do? So you have a beam initially with in a homogeneous environment that would create a flat ending here. So beam comes this way and then it stops. No beam in the back, but overall the range is the same. So having a compensator placed in front of it changes the range like this. So let's pretend the tumor is like this, then indeed you're shaping the distal edge of the tumor with the shape of the dose. And so this is true for homogeneous, but it's mainly the case for heterogeneous objects. So if you have bone in the way, that requires a larger range, and then the compensator will have a different shape. So here, and then now I come to the other method, and that is the pencil beam scanning. So you can see all these devices are gone now. It's only consisting of essentially 2 devices, and the beam shape hasn't changed. It remains the same. Only the location change, and this is achieved by having those scanning magnets. So they are fast scanning, and then deflecting the beam to different locations. On top, as I said, we have the synchrotron, which can give us any energy. In our case, for PDC-1, it was 94 energies, and so we can this energy, etc., etc., and then we can get different position of the target and can paint the entire target. So there was supposed to be an animation here, but apparently that's not the case. So anyway, if you overlaying the spot properly, then you can paint the entire target. Here's a schematic drawing of our nozzle itself with these 2 scanning magnets on the top. Oh, now it's doing something. So the first layer, another one, another one, another one. So it keeps on. So this is again the drawing for PTC1. So there's, unlike the Goitin paper mentioned that there are only 2 devices in it, that's not the case. In reality, there is much more in there. At least for PTC1, we could take out a few items in PTC2, but important items. So so what it has is you have here the beam coming in out of the window, then you have a profile monitor, you have a helium chamber, and you have the scanning magnet. Then you could have a scattering device that sits on the same axis as the X-ray tube. And then you have those profile monitor as well as the dose monitor. And then you have the energy absorber and the aperture. So there's a lot of stuff in the nozzle itself. But overall, what's actually impressive is that the overall thickness, the radiologic thickness, the length is 3.2 meter, quite a length on PTC1. However, the radiologic thickness of all the devices together summed up is only 3.5 millimeter. So very, very thin devices. So what can scanning beam do? So with scanning beam, we can create essentially all energies that we like. We can deliver the spots anywhere we want. That's as shown here. Another thing is cross plane versus in plane. So in other words, our spots have the same size regardless whether it's the x-axis or the y-axis. You see also that the size of the spot is a function of energy, and that's where I said this is the 455 maximum. I like that, but anyway. So you see, this is the size. It's about a cm for the highest energy and about 3 cm for the lowest energy. So how can you produce a uniform dose? By overlapping the spots. However, the spots needs to be placed in not too far apart, because if you do this and you have a spot delivering error, you can create a heterogeneous dose like this. So what you need to do, you need to overlay, or you need to bunch them together. And here in this case, in this example, the one spot was misplaced for 1 millimeter, and the spot size, however, was also 7 millimeter full of maximum. So it was an extreme case where he wanted to depict what can happen if you make the spot spacing not properly. So the spot spacing is a function of your spot size. So and that's something you need to take into account during planning. Another thing that you can see, all these spots in the schematics had the same intensity. So you don't need to do this. If you want to sharpen the penumbra, this is this portion here, then you need to make the spot on the side the highest intensity, and then the one a little bit less. Okay. So now comparing these two methods. So the passive one is simple, mature technology. However, it's inflexible, requires additional hardware for each field of each patient. It doesn't have any proximal conformity. It has more entrance dose. A large gantry size is required, and it's less sensitive to organ motion, and it produces more neutron. The active scanning is today's technology. It's flexible, no field-specific hardware is required. Superior dose conformality, smaller gantry possible. So it's sensitive to organ motion. That's one of the downside, and so the so-called interplay effect can play a role, and therefore gating and motion synchronization is needed. So let's go to the second part of the presentation, or the last part of the presentation, and that is essentially how we're treating patients. So it starts with all these. I'm a little bit behind the time, so let me skip this. So we're starting with simulation. So the radiation therapy uses immunization devices such as mask, vac lock, and leg immobilizer. And the goal is to have the patient reproducible aligned in the same way for every treatment. And because the CT image that we take are used for planning the dose. Another thing is, of course, for proton, we don't want to have any high density object in the beam path. So therefore, devices that we use, that we may use for photon, are not suitable for proton. So all of them are specialized for proton therapy. So this is an example for thoracic patient simulation. We have a so-called T-PAR here. This one, and this is called a wing board. And this is to support this this backlog. Here, this is a prostate treatment. So we have the leg immobilizer here, a little cushion here. Sometimes we use rectal balloon, but we have now the spacer as a technology that we use, and that's also, I mean, it's a different goal, but we use the rectal balloon less, and yeah, the spacer as an additional item. Sometimes we need to determine the bladder filling, and we do this by using the bladder scanner. Here, another simulation for cranial spinal. That's our latest simulation setup. So we have a mask as well, and we have a carbon fiber board, which is not visible because it's all black. And then we have a backlog as well. So, and one thing you may notice here is everything is extremely, really low dense, except the patient itself. And so this is what we're trying to achieve, and also uniform. Uniform is more important than the low dense, but everything is uniform. So that's and the same here on this end. Only the patient is heterogeneous, everything else is uniform. So then we have also tables with rounded edges here. That if a proton beam goes to this, it won't see the edge itself, but it's a round object here, and then you can treat the beam to this. So as I said, it's more important to have something uniform than to have the water equivalent thickness here. In this case, it's 7 millimeter, which is a little bit on the high end, but that's not the problem. The problem are these heterogeneous edges. So we're trying not to go to the sharp edges, because what's can happen is the devices can move relative to your plan, and then these devices are in the beam path, and every millimeter that you have in the beam path that's not accounted for will go further or will be short. The second portion of the planning is the registration. So the diagnostic images are superimposed to the planning CT, so that the physician can draw the target, because in MRI it's much better visible. Then the tumor is drawn in the TPS. The physician gives planning instructions. What is the prescription? What are our targets? What are our normal tissue? What we're trying to achieve? And any special additional items that we want to do. So then the symmetrist is selecting the treatment angles. So this is just one example of how you could treat this kind of thing. So you have the targets. Now you can treat with different beam arrangement to minimize the high dose outside the target. So what about uncertainty? So as I mentioned before, proton stop. And so that can mean that you can be over or undershoot. So that we can precisely measure this stuff in water, but in a patient, we're not so sure. So we have this stopping power CT number conversion that was suggested 3.5% by Michael Moyer. And this requires us to have distal and proximal margin. And so with that, we're losing the benefit of proton. So VMAT doesn't have an range uncertain because the fall off is always exponential. So therefore, we're losing a little bit. And one of the improvements are that we have dual energy CT and all this extra and PET that we mentioned here. And the other workaround on the software is to use robust optimization. This is being done now clinically for all patients that we treat with scanning beam. So that's an improvement that we, let's say, in the last few years achieved. So the other issue is artifacts. So artifact is a major issue that can perturb the CT, and as a result of this, the CT number inside the planning CT doesn't reflect what the actual tissue is, and that could also cause uncertainty. So and we have more uncertainty. So one is the position uncertainty that can be random or systematic. So as a mediation for this is the robust optimization or compensator smear in case of passive scattering. Or then we can have moving targets. We can do the compensator smear for the IMPT planning, and this is utilized currently for all our scanning beam plan based on the T0 and T50. We can use a Braffold technique in selected rooms if available. And then the other issue is the interfractional motion change, that is tumor shrinkage and weight loss. So other uncertainty is the RBE, and this is a hot topic right now. And the goal, so it can increase the dose to OAR, in this case the brainstem. Let's pretend this is a tumor here. So at the end of the range, you have a higher LET as shown here than at the entrance. And as a result of this, this can be not so good to your OAR and can produce side effects that you don't want. So one option is to have an LET optimization. However, this is not commercially available. So we're still waiting for it, and it's going to come out by the end of this year. So we're trying to get most uncertainty mitigated during planning, which is done by the dosimetrist or medical physicist. So as an example here, beam angle selection. In this case, we're trying to spare the cord. So this beam here is not hitting the cord. Here, on the other hand, we're allowing this to go to the cord, but then we need to make sure that this beam is blocking it. So one beam is going to the cord in this case, and one beam is blocking the cord. And so this way we can collimate the dose, but also minimizing the OAR. Another is planning margins. So for passive scattering, we use the Moyer formula, and using this 2.5% plus 3 millimeter, because our devices also contribute a little bit. And so on top of this, we have the setup uncertainty, which we will address with the compensator smear here. Lateral margins are addressed using the margin recipe from ICRU. So margin on the CTV, that's from CTV to the blue line to the magenta line is the PTV, and on top of this we go further. So an example for cranial spinal radiation, so including the boost. So you can see when the beam is coming from here, you're stopping, and the OAR essentially doesn't get any dose. So that's a prime example for proton therapy. And that the proton therapy works, you can see here by discoloration of the MRI. You can see that the dose overall is similar to what's shown here, which means that the range verification for this patient later on, we could really determine that that is how it means our model seems to be working. So scanning beam, I'm running a little bit out of time. So the scanning beam is different in this regard, that everything is software based, which means, well, yes, you have the beam angle selection similar to what you would have in passive, but then you let, based on these objectives, you do inverse planning. And doing inverse planning now, you can select a robust parameter, and then it produces a cost function shown here, and the cost function is minimized. And then with that, you're trying to maximize the dose in the tumor and minimize the dose in the OR. So there are two different techniques. I won't go to this. Now plan review. So the medical physicist checks the plan of whether all the steps that are recommended are met, and that the dose is to the best possible way. Then the radiation oncologist checks the 2D slides as well as DVHs, and sometimes we need to make compromises. For instance, in this case, the spinal cord sees a lot of dose, 49 gray, that's above our normal tolerance. And so we need to see whether this is acceptable, and this is sometimes a case-by-case call by the physician. And last step in this is before the treatment is the QA. So this is the scanning beam QA. We have our detector here. We're treating this detector with this gantry angle that we use for treatment. And then we compare the dose that we have calculated in water with the dose that we have delivered. And this is shown here. Measured dose versus calculated dose, and then you have a good agreement here if your treatment planning model is good. On top of this, we also have the option to monitor the delivery. So the devices that are in the nozzle gives us signal and gives us a DICOM file that says what is the treatment record. And this treatment record contains the content of how many MUs delivered to the individual positions and where have you delivered the spot. And so if there's any and here you see the deviation from the planned value. So you can see this is all within a millimeter here. And the last thing is the delivery. So the patient, this is stylized pictures, not how we would treat. We treat typically over 10 to 39 days, and the dose per fraction typically is between 1.5 to 3.7 gray per fraction. So in summary, the proton have some unique properties which are found to be useful in producing high conformal dose distribution in targets and reduce the dose to OR. The use of spot scan proton beams has the potential for dose painting with reduced neutron dose, and mitigation of known and unknown uncertainty are essential to achieve a fully potential of proton therapy. This remains an active area of research and development. Okay, thank you very much for your attention, and let me know your questions.
I have one question about the RBE calculation. What is in fact, I know you talked about that, but what is expected to be known in the next steps? So I know that an RBE of 1.1 is more or less accepted, but do you think that we need further studies on this, or is it a research area to be improved or not?
It's a very difficult topic. But we're making progress on this end. So in theory, it's all variable, but and all of these data, so the main issue is this: all the data are based on cell experiments. So cell experiments aren't human tissue, and so that's the main issue. And the other problem that you have in a patient, you cannot look into the patient and tell what tissue I'm having here. I have only CT numbers there. I can't tell, is that even tumor, or is that because in the microscopic sense. So the GTV is obviously the tumor, but if you are going beyond the GTV, CTV, is a tumor? No, it's not. it's still mostly it's mostly healthy tissue that's infiltrated with tumor. How this reacts to RPE? Different. So the problem with RPE is this. So in the formula is that you're incorporating the LET as well as the alpha beta. So the linear quadratic model, the two parameter, the linear component and the quadratic component, that alpha beta is a function of tissue type. And so you need to know the tissue type beforehand in order to accurately determine the RPE. And so, but the contours to determine the tissues are drawn by the physician based on the what they see in the diagnostic images. So then because of this, the alpha beta has such a big effect, it will change the RPE by a lot. So one solution for this, what the vendor came up with, saying, I have an average alpha beta for common tissue areas. And with that, I'm getting away with this. And that way, that gives us a linear relationship between LAT and RBE. Okay, so then the second issue this is the first issue. The second issue is that you need to decide on your model. So everybody comes up with his own model. So the own model to translate the LAT into RBE. So that's the second item, and the user has to pick the model which they are familiar with. But so the way I approach it as a clinical physicist are I want to evaluate. So first of all, if the LET is low, then the RBE will be low. That's just practical. Okay, so this means if I can minimize the LET, which I can accurately calculate with Monte Carlo, then I will not have high dose in the OR or additional dose over the one that shows in the plan. The second step is I can evaluate or potentially calculate the RBE based on a model that I like and using a fixed alpha beta, what dose would this correspond to? So to give it more of a quantitative way for the physician to evaluate the dose. So that's the second step. So we are there already. So we have this available in our system. And the third step is then actually the plan. And that's something that's not available yet commercially. We have this on our research computer. We have such a thing, but it's a lot of work from physicists to make that work. So the physicists are using their in-house optimizer to modify the spots. In my opinion, that's not really clinical working, so it's not applicable for everybody. So that's something we hope to get soon, and then this will improve. And of course, this all happens because we have scanning beam. So for passive scattering, this is a little bit less of an issue considered. And so for scanning beam, is more of an issue. And because of this, since scanning beam is now more common, more people are working on it. So there's more progress on this than has been in the past.
Thank you so much. We do not have more questions in the from the audience. So Professor Falk, thank you so much for kindly give us insights on the principles of proton therapy. And now I think we can move on to the next speaker. The next speaker will be Professor Thomas Whitaker. He is an associate professor at the Department of Radiation Physics, Division of Radiation Oncology, also from the University of Texas, MEDAC. His research interests focus on the outcomes research and knowledge-based planning. This includes novel methods for constructing large data sets, machine learning, deep learning, techniques to perform patient outcomes research, as well as knowledge-based planning. In the clinics, he has a full spectrum of radiation therapy, clinical practice experience, including in proton therapy, that is the topic of our session today. On this area, he provides technical oversight of the radiation therapy informatics, works also collaboratively with dosimetrics on proton therapy planning, and also with the information technology personnel to support clinical information systems, and also performs quality assurance of proton therapy plans and quality assurance of proton therapy delivery systems. Professor Thomas, thanks for accepting our invitation to share with us a small part of your strong knowledge on proton therapy, addressing the topic image guides planning and delivery of proton therapy. You can share your presentation and the floor is yours. Thank you.
Awesome, thank you. Sorry for making you go through such a long introduction. This was my promotion year, so the bio reads a little longer than normal because of that. So Falk nicely covered actually quite a bit of the early stuff. He covered a lot of the early matter, so we can probably catch back up by not going over it twice, and then have a few questions at the end. So I'm mostly going to focus on image guidance and with a secondary focus on managing motion of the tumor. So Falk's already given you a good overview. You probably got to see a picture of our center. We're currently treating in what we call Proton Therapy Center 1. It opened in 2006, which makes it one of the early leaders in proton therapy in America, and was, state of the art in 2006. And we're just about to open. In fact, I've been mostly busy commissioning our second proton therapy center, which should treat its first patient before the end of the year. It's similar in size, so all of the gantry stuff that Falk gave you is very similar, but in this case, it's all going to be scanning beam. You saw the immobilization, so you know why we do immobilization. The key to remember, I just want to highlight what Falk said, which was for radiation therapy, the CT functions as a 3D model of the patient. And that's really important. So unlike an image for radiology where they might be able to zoom up and just get a super beautiful image of the affected area that they need to look at, we need good detail up close at the tumor, but we also need to preserve the overall external integrity of the patient as well, and any of the immobilization that we might pass through, because again, we're going to have to model the beam trajectory into the patient. Now, for motion management, it's important. There's a few little things to note. This patient has a belt, and this is what we call a bellows. And that's because it has like a little bellow in it with a transducer. And as that bellow is stretched or allowed to relax, we can see the breathing waveform of the patient. And so we can get that motion. And then of course, if we couple this with a CT, we can get a surrogate of the external breathing of this bellows with the motion of the tumor internally. And similarly, a very popular product across the world is the RPM by Varian. And that little box has a reflector on it, and there's a camera here at the end of the table. And as the box moves up and down, again, the camera sees it, we see the breathing waveform, and we can match that breathing waveform as a surrogate to the motion of the tumor that we see in the 4D CT. Here's a set of immobilization, but Falk covered that. And I didn't realize he was going to be covering treatment planning, and he did so in much greater detail. But again, this just simply highlights the fact that the CT is more than just a way for us to learn about the shape of the disease itself. It's also our 3D model for how we need to prepare the treatment, what beam angles we need to choose, what depths we need to treat to. You know, it's the model that we're going to base it on. Yeah. And so the information, the treatment planning system, I don't know if Falk actually did say this. The information that we're primarily going to use is the CT number, so the HU, but then we've got to convert that to an electron density if we're doing a photon calculation, or to a stopping power if we're doing a proton calculation. So again, we can probably just skip right over that because, you know, this was described earlier, but the 3D model lets us produce conformal dose distributions, and then we can evaluate those on a 2D or a 1D evaluation as well, using something called a dose volume histogram. So that's how much dose went to how much volume, whether it's a critical structure or a tumor or a target that needs to be treated. And so for targets, obviously, we want to cover that 100%. And for critical structures, we want to minimize that. Some structures, say like a parotid or a liver, you want to separate out, it matters how much volume gets treated. So maybe we want to spare half of it, but the other half, we can go ahead and treat to a dose that would, you know, be destructive, but then it'll still maintain function of the organ. But other organs, say like a spinal cord, are a serial structure, and because they're a serial structure, a maximum dose is usually our limiting point. Once we violate a certain amount of dose to that structure, we can completely deactivate it, regardless of how large the volume is. And that's not 100% true, but you get the idea. Okay. So, sorry. I was just making sure I could see the chats. Then, as we move on to treatment delivery, and again, focusing on the IGRT side of this, this is an up-close view of the Proton machine at a Proton gantry at PTC1. Embedded in the wall of the gantry are imaging panel, like an imaging source, and an imaging panel. There's another imaging source inside the nozzle itself and an imaging panel. And these extend out of the wall and allow you to create orthogonal imaging for the patient. This is also true in, you know, photon radiation therapy, in which there's usually a, you know, a treatment head in which megavoltage X-rays are used for treatment, and then a kilovoltage X-ray source for localization in an imaging panel. Here's another vendor, their X-ray source and their X-ray panel. You can actually take an image with the megavoltage beam as well. And so there's this down here is a panel. Sorry. This down here is a panel, and sorry, I was going to, yeah. There we go. Maybe, I guess I can't draw. And But the megavolted images, lack the contrast, and so they're not as useful. So typically what you would do is you would X-ray from one direction, rotate the head, X-ray the other. And that way you can get orthogonal radiographs. So this is the most the simplest form of image-guided radiotherapy, and we've had this technology for a very long time. And so we can simply take an X-ray, compare it. So here's the X-ray over here, and we can compare it to, it really doesn't want to let me draw, to a digital radiograph created from the CT. So this one is a synthetic radiograph created based on the CT, and here's the real one, and then we can compare them and position the patient correctly prior to delivering treatment. Sometimes you want to use soft tissue. You don't want to, a bony anatomy is not enough, right? And the prostate is maybe a classic example of this. The prostate itself, from a day-to-day basis, so from tomorrow to today, could shift on the order of a centimeter. And that's because of the bladder filling and bowel filling that happens. But on an actual treatment basis, it only moves typically a few millimeters over the course of, say, 10 minutes. That's kind of your operating window of which a prostate is typically stable. So we need the ability to move with respect to the bony anatomy and follow the soft tissue. To help us do that with simple radiographs, we put in gold fiducial markers. In proton therapy, a lot of times we actually use a carbon marker. It's actually a zirconium oxide marker coated in carbon, but they call them carbon markers, that are a little bit less dense, perturb the beam less than the gold does, but still show up nicely on the radiograph. So whether it's gold or the zirconium, the point is it's a marker that shows up on the X-ray that we can then shift the patient with respect to, so that we are targeted exactly on the prostate itself and not follow the bony landmarks. Of course, you can use this in other areas. Other common areas might be breast tumors or liver lesions are maybe the next most common. But we have more technologies than ever, and now we actually can take CTs at the treatment machine, and this is true of most modern proton therapy centers as well. We now have the ability to take cone beam CTs. This has been available on megavoltage photon machines for, I don't know, 15 years or so. So it's been around for quite some time. So we can place the patient on the table, we can take a full cone beam CT, and then we can do full volumetric matching and register those two images and get the shifts we need to make on the couch in order to put the patient in the best position. The nice thing about that is now we're not as reliant on soft tissue markers. Not all tumors are reachable by soft tissue markers. Specifically, you can think lungs. You can put a marker in a lung, but your complication rate for collapsing the lung is relatively high. It can be as high as 10%. And so that's a fairly major complication. And so having the volumetric imaging really helps quite a bit. Even for things like prostate, even though we had a good option for prostate, it does allow us to, say, follow the anterior rectal wall. So now all of a sudden, not only can we position superior inferiorly, maybe based on fiducial markers, but we're able to say set that anterior rectal wall exactly where it needs to be. And that's kind of the main organ we're trying to protect anyway. Okay. So I like to think of dealing with motion. So now that's just like how we image things. But let's start, excuse me. Let's start talking about how we deal with motion and what types of motions we might experience. And so there's the obvious, the tumor can move. This could be a lung lesion, it could be a prostate, it could be an esophagus. But then we also have normal tissue motion that we might have to deal with. Then there's mechanical motion of the machine itself, and that we might need to deal with. And then there's also the motion we want to induce to potentially separate tumor from critical structures. And so we'll kind of cover those as we go through. So as we think about tumor and tissue motion, I like to think about this anatomically, because then it becomes a little bit more intuitive to me. And based on the extent of the motion also helps us to decide how we're going to manage that motion. Okay, so as I look at the body, the motion is mostly being derived by the motion of the lungs, right? And so as we're at the very top of the apex of the lung, there's very little motion, less than 5 millimeters. Then as we drop down to the level of the heart, it's increasing. It's very possible at this point we are seeing motions greater than 5 millimeters. As we get to the diaphragm, this is going to be our largest area of motion, and this can exceed 1 centimeter for a lot of patients, if not most patients. But then as we get beyond the diaphragm, we start seeing that motion start coming back down. The abdominal area still probably greater than 5 millimeters, but when we get to the pelvis, almost no motion actually due to the diaphragm. Although, I mean, technically there probably is a little bit, but it's small. There in the pelvis, we're really thinking about motions induced by rectal filling and bladder filling, in which those time scales are slower. Yeah, so they're slower. Okay, so we can start then breaking these down into, you know, potentially areas of the body that we're going to treat. So we can expect these lower lobes, again, and liver lesions to need some kind of motion management because they're going to be greater than 1 centimeter. And we want to think about our motion management likely being used anytime we're greater than 5 millimeters. That some kind of active motion management, I should say. Okay. And then, so down in the pelvis, we might not have that target motion, but we do need to consider sometimes we're going to treat nodal regions in which the soft tissue or the normal tissue around it is moving with respect to the target, and that may cause us some concern. Okay, so how do we assess motion management? Well, the only good way is really to get a 4D CT scan. Okay, and so we get our 4D CT scan, and that allows us to see how much motion the tumor has, see how much motion the surrounding tissues have, and decide what kind of motion management technique we might want to employ. There are 4 kind of main methods for managing motion. One would be to just treat a larger volume. The others would be to, in the active sense, to do gating. And then we can use breath hold technique or abdominal compression, which is both, I guess, active and passive, if you want to think of it that way. So let's go through those. Treating a larger volume. So the volumes that we break down usually are, so the gross tumor volume, so that's the tumor itself, and then there's a space around that volume that needs to be treated because there is disease in that volume. Although it's not visible to the naked eye, we know that there's a certain space around the tumor that needs to be treated. We call that the clinical target volume. And then we can have a larger volume beyond that, which is for motion management. And so we can simply, if the tumor moves like 10 centimeters, well, we could put a 10 centimeter margin around that target. Now, there are some positives, and the positive is it's easy. Almost every clinic is able to do this. If not every, I guess every clinic is able to do this. You don't need any extra tools, no software, no training is needed, because you're just simply increasing the amount of tissue you're going to treat. Now, that's also one of the reasons not to use it is because you are then increasing the amount of normal tissue that is being treated that doesn't necessarily need to be treated. And then beyond that, depending on your delivery method, in the case of like scanning beam, we could actually have an interplay effect between the motion of the beam and the motion of the target. And so sometimes in some situations, covering a larger volume does not necessarily even provide you with the result you want. And then in this process, we need to think of how much the range of motion there is. If it's less than 5 millimeters, the ITV is actually a really great solution. That's not a huge amount of extra tissue. And it's the most comfortable method for the patient themselves. But beyond that, beyond 5 millimeters, we really should be thinking of some kind of active management. So what does active management look like? First might be gating. And so for gating, how that works is we watch that surrogate, that external surrogate move up and down, or in this case, the bellows stretch and contract, and we get a waveform. We've already correlated that waveform with the motion of the tumor in our 4D CT scan. And so now we can put little gates on the breath hold trace, and we can turn the beam only when the tumor falls into that particular gate. And so, what are the pros and cons of this? Well, it's very comfortable for the patient because they don't really do anything but sit there and free breathe. But you do need some specialized equipment, and you need some specialized training to manage that equipment for the patient. If a patient breathes too rapidly, there may not really be enough beam on time because the machine is always stopping and starting. This is particularly a problem in protons where it's not so easy to start and stop. For photons, it's a little bit easier for some machines, not all machines. And with proton therapy, the duty cycle can become so low that it just results in very, very long treatment times, which is hard on the patient. So the most common motion management technique that we use is breath hold and deep inspiration breath hold. And I separate those two out, those two different breath hold techniques out because we're going to use them in different ways. So breath hold is simply just a way to increase that duty cycle. So to increase the amount of time the gate is on. So we have a patient take a breath and hold it at a comfortable level. It needs to be a little bit high, but it doesn't need to be extremely high. And then we can threshold, you know, on the height of this breathing trace, again, from our surrogate block or our bellows. And because they're holding it, now we increase that, you know, to 30 to 50 seconds. And that gives us a nice beam on time for which to deliver the treatment. So it's less comfortable than simply free breathing, but most patients can hold their breath for 30 seconds. And if they can do that, then this is a really good technique for them. If a patient cannot hold their breath for 30 seconds, this is not a good technique for them. And so we would want to use some other method. But let me also then talk about the deep inspiration breath hold. So this goes back to sometimes we want to increase space between a critical structure and a target. And so breast tumors are the most common usage of deep inspiration breath hold. And you can see here, if the patient's normally free breathing, yes, there's some motion of this tumor, but that's not what we're really concerned about. We're concerned by the fact that the tumor sits essentially on top of the heart. And so by having the patient do a deep inspiration breath hold, we can pull that chest wall up off the heart and get good physical separation of those target and critical structure and make major reductions in the dose to the heart by doing so. So deep inspiration breath hold, the only real difference, technically it's the same. The only difference is now we're going to have the patient breathe into an extreme position so that we get as much separation as possible. Okay, so when a patient is not able to, hold their breath for 30 seconds, but yet we need to stop that motion, like the motion of the tumor is still greater than a centimeter or greater than 5 millimeters, we still need to apply some kind of reduction. And so another method is abdominal compression. And here we have this frame that attaches to the table. There's a paddle in which you can screw down onto the patient so that you're pushing the abdomen down with pretty significant force. And this reduces the patient's ability to take a full range of motion with their breath. This is not at all comfortable for the patient, which is why it's maybe one of our least favorite management tools. But when all else fails, and if that's what we really need to do, it is a method that does work. And you need to be careful to make sure that the compression you're applying is repeatable and that it is causing the motion to really be restricted. Because if you don't push it down far enough, the patient can still breathe pretty reasonably, and the tumor could move upwards of a centimeter still. So you really have to apply quite a bit of compression, which is why it's so uncomfortable. We also can do some motion management using the treatment planning system itself. And so particularly in protons, unlike photons, we're very sensitive to changes in density. And so using the treatment planning system, we can sometimes provide density overrides so that we build into the plan the fact that sometimes there's going to be normal tissue there and sometimes there's not going to be. We can create a plan in which there's normal tissue kind of through the entire beam path, and then we can evaluate it without that override. And so this is very common with things like large esophagus fields, because the esophagus itself, that whole area is not actually going to move very much. So we don't have to be worried about the interplay effect on the target itself. Maybe the normal tissues a bit, but not the target itself. And we don't have to worry about, so we don't have to worry about the motion of the target. But we do need to worry that when the diaphragm moves superiorly, that if we didn't plan for it, all of a sudden that diaphragm is going to block the target and create a cold spot. So again, we provide these density overrides, we create a plan, and then we evaluate that plan both at two different phases, at the 0 phase and the 50 phase. And so we then evaluate all 3 scans, and if our DVHs are consistent across all 3 for both critical structures and target, then this plan is now robust to that motion, and we're able to treat without any active motion management. Okay, so we've been mentioning the interplay effect quite a bit. It's maybe the most difficult concepts in motion management. And so we'll spend a little time talking about it. So what is interplay? Interplay is the correlation between the motion of a tissue and the motion of a beam delivery system. So if we have passive scattering fields, or if we have open 3D fields in photons, we're not worried about the interplay effect because the motion of the beam delivery system is static. We only have the target motion, and so we don't have to worry about that. But if we're doing IMRT or IMPT, or any form of scanning beam, we now have a delivery system that's delivering radiation with motion. And if the motion of the tumor and the beam get synchronized in negative ways, we could have hot and cold spots. So if the tumor at t equals 0 is up here and the beam is down here, then we just missed. And vice versa, as it moves down and the beam delivers up high, we missed. And so we could have these consistent cold spots. What's also true is we could have consistent hot spots for normal tissues as well. If for every time the beam is coming on, a piece of normal tissue just happens to move itself into that that space where the beam is delivering. And so how do we mitigate that? Well, first and foremost, we need to get that motion down. So we're going to do some kind of active motion management. But then we can also change. So that's okay. Sorry. So you can think of it as 2 ways. Again, it's the motion that we're trying to it's the interaction between 2 motions. So we reduce the amount of motion by the tumor, but we can also increase or decrease the motion of the beam. And so this allows that synchronization to be broken up. Okay. And so one of the methods after we apply the active motion management is to reduce the amount of MU, and that's the monitor unit, which is like the packet of dose we deliver to any one spot at any one time. So we still need the total amount of dose to a spot to be the same, but we don't have to deliver it all at the same time, right? We can take the amount we deliver at any one time and start chopping it into smaller and smaller chunks. And as we do that, it'll deliver the small chunk, move somewhere else, deliver a small chunk, move somewhere else, deliver a small chunk, come back and deliver another small chunk. This method is often referred to as repainting. And so in that way, we can take that total dose and we can repaint multiple times until we get the entire dose delivered. So there have been a number of studies, one of them done here at MD Anderson, Kadar and Zhang et al., analyzed the dose to given targets as you take this parameter, that the mu per spot, and shrink it. And so you can see as you get smaller and smaller, you get closer and closer to the static dose. It takes longer to deliver, for sure, but it's not horrible. It's not a huge cost in delivery time. Okay, so now I just want to kind of leave you with how to make the clinical decisions. And I think this is kind of maybe the hardest part, is there's not a single strategy that works for all patients. You have to look at it from an anatomic perspective and a patient specific perspective in order to choose the right motion management strategy for each patient. But they roughly kind of fall into certain categories, which helps because now we can have a decision-making process tree to help us choose the right motion management. So, our main goals are always to, get all the data we need to treat a patient. But we also want to, do it in the most radiation efficient way possible. And so when you think about that, you have to think about it pretty critically. It doesn't mean don't take lots of images if you need lots of images, okay? And that's the critical thing. We may have to take 3 or 4 CT scans if we're going to do breath hold. We might have to take a 4D CT and then 3 or 4 CTs for breath hold. But that's because we need all those images to make a good decision for that particular patient. But what we want to avoid is not getting enough information and having to bring the patient back and delay their treatment, or taking too much. Like, we don't need to take like 10 breath hold scans if 3 is enough, right? So it's that balance. Okay, so I like decision trees. I think they are helpful to think through processes. They're also great for the clinic where we have lots of different people. The therapists are often more or less taking the CT scans and making lots of decisions without somebody sitting right there, or the therapist and the physician are making all those decisions, not necessarily with a physicist standing right there as well. And so if we all sit down and agree on a process, then we're much more likely to get the images we need to treat the patient properly. And so let's think about situations for things like lung, liver, and esophagus, where we know in the beam path either the tumor is moving greater than 1 centimeter or the soft tissues are moving greater than 1 centimeter in the area that we need to treat. We're going to start by assessing the motion with a 4D CT scan. And then we're going to ask ourselves, what is that tumor motion? So we can measure that right there at that time. And if it is greater than 1 centimeter, we're going to move on to one process. But if it's less than 1 centimeter, then we can ask ourselves, oh, well, is this a chance for us to maybe use a maximum intensity projections to build an ITV? then treat on an average CT in the treatment planning system and evaluate with 0 and 50 phase on the treatment planning system so we can make sure that the plan is robust. So that's definitely an option. And then if it's greater than a centimeter, we need to have some kind of active motion management. For proton therapy, our go-to is breath hold, so we'll assess the patient for breath hold. Now, I mentioned the key to breath hold is that a patient needs to be able to hold their breath for 30 seconds. So if a patient is able to do that, then we're good. We go on and collect the breath hold scans. Typically, we need 3. We want to make sure that if the patient breathes into the gate, that the tumor stays in the same place. And so we'll take 3 of them, make sure that the motion and breath hold is reasonably correlated, and then we can go on to pick one of those scans for actual treatment planning. If the patient can't hold their breath for 30 seconds, then we need to figure out what we're going to do. And that becomes then, a discussion with the physician, should we use abdominal compression? Should we, should we think of another modality that maybe it's not such a big deal with? So there's that. So now we can go to partial breast. Again, for the partial breast, the key was we're trying to create that mechanical separation between the tumor and the critical structure. Now, first and foremost, not all patients' tumors or targets are sitting on top of their heart. So we can take our free breathing CT scan and evaluate how close that target is to the heart. Now, assuming the heart is outside of the treatment field, then we can just, I don't know if I think I reversed my yeses and no logically. I apologize for that. Assuming if the heart is well outside the field and we have good separation naturally, we can just use our free breathing treatment scan and we're good. We don't have to take any more images. But if the tumor is sitting on top of the heart, now we need the patient to take a deep breath hold inspiration, and we do that same evaluation of can the patient hold for 30 seconds. We acquire the scans, we get more images. So you can see here we have a chance to save imaging to the patient based on patient specific criteria. And then similarly here for esophagus, we have situations in which we need to know, is the target close to a dose limiting critical structure? In that case, we're going to need to use IMPT planning. If it's not, we can then just simply use passive scanning. If we're using passive scanning, we don't have to worry about any type of interplay effects. And so we can just go to maximum intensity projections and density overrides and check. If we do IMPT planning, one, it's a limited resource for some centers, including our current center. So that's one of the main decision-making reasons for this decision-making tree. But two, now we need to potentially get that 4D CT scan so we really have motion management capabilities. I guess we're going to do 4D CT scans anyway in this one. So here it's not quite as critical of a decision-making because the imaging is all mostly going to be the same. It's really whether we're going to be able to choose passive scattering versus IMPT planning. Okay, so that's my talk. I'm happy to take any questions on motion management or any other topics you want to just chat about.
Thank you, Professor Thomas. I have one question, but it is not a so scientific question. It's more maybe how is the patient addressed during this process? So does he has conscience of the need of, for instance, if he needs to hold the breath for 30 seconds, he knows what are the consequences of not doing that. How is this addressed in the close contact with the patient?
Right, yeah, so in all of the active methods, patient education is critical. And so they typically have like a feedback goggle. And it's not always a set of feedback, it's some sort of feedback. So we're getting better and better. Like now we can make the room change colors. We can have just like a projector screen above them where we can give them that visual feedback. But they have some sort of visual feedback. So they can see when they're holding their breath in the gait properly. And then then we just have to kind of decide how much real information, like we don't want to stress the patients out. They're going through a lot, but you know, we simply just say, okay, take a deep breath and hold it. And we watch the clock. And you know, if they're not reaching the gate, we say, okay, you see that little bar, now we need it to go just a little bit higher, try to get it into that area on your screen. And once they get it up there and hold it and say, okay, now hold it. And then we watch the clock. And when it hits 30 seconds, you know, we often can just say, okay, you can breathe again. Maybe we just see. But we're mostly really looking for how they can do that like 2 or 3 times in a row.
Okay.
Because lots of people can hold their breath for 30 seconds, but they can't like do it a second time and a third time. But we can do all of that without turning on the CT, right? That's a full, like we just do that while they're just sitting there, laying on the table. If they're kind of borderline, maybe we would then intervene a little bit more and say, okay, look, we really need you to try to hold a little bit longer. Like right now we see you holding for about 25 seconds. We want to see if we can get you to 35 seconds. Do you think you could do that? It's usually pretty obvious if somebody has really has real breathing problems. It's like 15 seconds and it's over.
Mm-hmm.
And there's nothing, they're not going to be close. There's no real decision to be made. Sometimes you actually have the exact opposite problem, which is somebody can hold their breath forever, which sounds awesome, but mostly it's because they are manipulating their body to hold the bar in the place, and now they're kind of squirming to get this box, and maybe they're pushing the, you know, using their belly to hold the box in the right place, but are able to still breathe. So you have to actually manage the other side of it as well. And so that's kind of, again, patient coaching. And you do that at the time, which is like, okay, go ahead and take a breath. Like you let them recover, whether they want to or not, you tell them so that they recover. But there is a lot of back and forth. But we don't necessarily tell them everything up front ahead of time, like, okay, you need to do breathing by 30 seconds or we're not going to be able to do this, because that's just anxiety provoking. And it may not be true because if that patient's going to do 20 seconds, but this patient is perfectly curable, but will die if we don't try, we may break a rule and say, okay, this is not our best option, but it's yet our best option. So we're going to go ahead and try, right? But we try to use these algorithms so that we can steer the patients to the right technologies to make their treatment as smooth as possible. Yeah, sorry, I don't know if that answered your question, but.
Yes, of course. So it's very difficult to manage, but it's a challenge. But it is. There is a need of take in consideration the what the patient is going through. So of course it's important. Okay, so I think we don't have any more questions, Professor Thomas. So thank you so much for your time with us. I think it was very, very great to have this perspective and the advances and also the challenges for proton therapy, and in particular the image guides planning and what it can give us in the clinics. So thank you so much.
No problem.
Professor João Seco will talk about real-time PGS raging monitoring in proton therapy for of prostate cancer. Professor João Seco is Professor of Physics at the Department of Physics and Astronomy at Heidelberg University and group leader of the Biomedical Physics in Radiation Oncology group at the DKFZ German Cancer Research Center. His current research interests are to develop novel imaging technologies to reduce the Bragg peak positioning uncertainties for ion beam radiotherapy using helium beam imaging and prompt gamma spectroscopy, and to investigate the mechanism of radiation trigger DNA damage through reactive oxygen species. This year we have the privilege of having him in real time. Thank you very much, Professor João. When you want, you can start, please.
Thank you very much. I notice I really have to shorten my introduction next time, so to make it simpler, but thank you very much for this introduction, and I want to thank the organizers of the course for inviting me back for the second time. Okay, so I will talk about prompt gamma and how we can use it for prostate cancer. And why particle therapy? I think you've heard it already in several talks before mine, the importance of the Bragg peak. So I'm just representing it here again. And you see the Bragg peak, you try to position the Bragg peak right at the end, or very close to the organ at risk, but right at the end of the tumor. And this is something called an ideal situation, right? And this would be the reason for it. You would have a lower toxicity because there is no exit dose. You could potentially have better tumor coverage. And with the Bragg peak, you also have the advantage of using less beams. So the main advantage of particle therapy is the organ sparing ability. So you reduce, in principle, if you can control the Bragg peak, you can reduce the amount of dose that you give to distal organs. And this reduction should, in principle, translate to clinical advantage, of course. So this is the case of one Bragg peak, okay? When we treat tumors, we don't use one Bragg peak. We use what is called a spread out Bragg peak, and they are made up of a few Bragg peaks put together to generate approximately homogeneous spread out Bragg peak. And this is what we sometimes call SFUD, single field uniform dose. This is the simplest way to deliver, and it's what's been used almost since 1954, since the first treatment. Okay, so uncertainties have also been mentioned in the various talks. The key problem of the uncertainties is the Bragg peak is never exactly where we want it, right? There is also the shift, and the shift could lead to the fact that the dose can go straight into the organ at risk. So on the left side, you see a shift from the red to the green, and this could be an uncertainty in the positioning of the Bragg peak, and that could lead to a fact that you deliver the dose potentially to the organ at risk. And to avoid this, treatment planning with proton beams have avoided shooting straight at the organ, as you see on the right, and they usually use the lateral beam. So now you see the red beam is no longer used because of this uncertainty in the Bragg peak. And what you use is you use the lateral penumbra to really match the edge of the tumor to the organ at risk. So what we would like to do is to use the left side for treatment, but we tend to use the right side, which is not optimal. Okay, so what happens with uncertainties? Well, if your Bragg peak goes into the organ at risk, you have what is called an overshoot, and this can lead to damage to the OR and some toxicity. But you can also have the situation that you have an undershoot. So instead of going to the right, it's going to the left. In this case, your tumor is not fully covered. Your tumor is not fully covered. And this leads to also a poor tumor control. Right? Situations that can produce this are ambiguities in the stopping power, patient setup alignment problems, anatomy changes between inter and intrafractions, and organ motions. Many of these have already been addressed in the previous talks. Okay, so the talk, I've broken the talk up into several sections. The problem of the Bragg peak, I'm going to mention this in more detail. I'm going to provide a motivation for the in vivo range monitoring, and then I'm going to mention many of the range monitoring technologies currently available. Then I will focus directly on the work we've done on prompt gamma spectroscopy, and this is divided by two centers. The first 5 years I was in Boston developing this, and then the last 8 years I've been in Heidelberg developing this. And we will show then, of course, results for the cyclotron from the Boston cyclotron and also for the synchrotron for the Heidelberg synchrotron. Okay, so just a quick reminder, on the left, you have a brain cancer, which is in light blue, and you have your organ at risk, like your brain stem. And you have a fictitious representative on the right, what you would like to do. So if you treat the brain stem, you would shoot one beam, and you would like that beam to cover the tumor, right? So the red part, which is represented by the beam, is covering the tumor and trying to avoid the brain stem as much as possible. And so if you look at the top right curve, you see that you have the SFUD, the spread out Bragg peak, is supposed to stop just before the organ A, and it's lateral to the organ B, right? Now, in reality, because of range uncertainties, we have to add a larger margin. This is what we call a PTV. And this larger margin immediately goes into organ A, right? It doesn't affect so much organ B, but it does significantly affect organ A. And this range uncertainty is what is usually the major problem in the way we use particle beams. And you see on the left the impact on the brainstem. By just adding this additional margin, we are directly over-irradiating the brainstem. So how do we calculate this? There's a variety of recipes depending on which center you are at. Here you have a variety of recipes from MGH, from Florida, from MD Anderson, from PSI. All these have different representations. The one I was used to using is the 3.5% plus 1 millimeter. That was the MGH one. And you see that it changes with depth. So on the horizontal axis, you have the depth of the Bragg peak. And the vertical axis gives you the additional margin that you have to add in to account for the range uncertainties. So if you take 10 centimeters, you see the margin varies between 4 millimeters and 6 millimeters. And if you take the 20 centimeter deep Bragg peak, now it varies between 6 and 10. So it's a very large margin that you have to add in to cover this range uncertainty. So this is a major problem. And what's the distribution of tumors that you usually treat, right? The majority of the tumors are treated 10 centimeters or deeper. So this is a distribution of different types of tumors and the depth at which we're shooting. So the blue represents the brain and the head and neck type tumors. The red represents the thoracic region, and the green represents the abdominal. And you see that many of the lung and the abdominal are pretty deep tumors, and close to 90% of the tumors are 10 centimeters or deeper. So you're in the range of at least 5 millimeters extra margin, and sometimes it can even be more, 8, 9, or 10 millimeter margin. So you're voluntarily adding this margin to take into account the range uncertainties, but this is a problem because you're overshooting into a critical organ. Okay, so the motivation for in vivo range monitoring. So we want to use range monitoring so that we can do many things. So the top left corner says that if we can do range monitoring, we can reduce the margin. This has already become a clinical practice in Oncore in Dresden. They've been able to reduce the margin from around 3.5% to 2%. And this led to a reduction in toxicity. Then the top right corner represents the normal tissue complications or toxicity represented by the red curve, and the tumor control represented by the green curve. So if we can control or monitor the range, we can decrease toxicity and increase tumor control. Also, the ability to control the range is very important for quality assurance. All treatments have to be quality assured at least once before treatment, and this is important. And you also want to do daily verification. And then the final advantage of range monitoring is, of course, the ability to use head-on beams. So here on the bottom right corner, you can shoot straight at the heart, for example, and if you can control the beam, it's not a problem for the heart. Okay, so what is the goal of most range monitoring uncertainties? We want to achieve around 1 to 2 millimeters, if possible, by monitoring real time. And this is still a dream, but it's getting closer and closer to this reality. So what is the difference in the distal fall off relative to the lateral? Right, the distal fall off is much sharper, which means we can really aim at the organ, and if we can control the Bragg peak, we can basically stop just before the organ. While the lateral fall off is much broader, and so it's not ideally suited for lateral protection of any organ. So you see that the hot dose, the red dot, is much closer to organ A than it is to organ B. So this is a big advantage of using the distal fall off over the lateral fall off when we do protons. Okay, so what are the monitoring technologies out there? So for many years, a variety of monitoring technologies have been investigated, from implantable markers to proton radiography, MRI, PET, ion acoustics, and prompt gamma, which is my specialty. Many of them have done a variety of studies, from online to real-time, non-invasive, and so on. But I'm going to focus primarily on the prompt gamma, which is now in clinical use. And it's also commercially available, but not as a full product. You still have to develop a lot of these things. So the prompt gamma offers online in real time. It's not invasive. It is extremely accurate once you've developed the technology appropriately, and it's commercially available, but not the full system. You have to build up the software for doing this. So what is prompt gamma spectroscopy? Prompt gammas, when a particle hits a nucleus, like a proton or carbon hits a nucleus of an atom, like oxygen or carbon, what happens is the nucleus becomes extremely excited. And this excitation leads to a de-excitation with emission of your prompt gamma. So the prompt gamma comes from the de-excitation of your nucleus. So they release this energy in the form of gammas, among others, and we pick up these gammas to identify where the beam is hitting. So here's an example of a pictorial representation of how you do it. You have the red line representing a proton beam or carbon beam that's coming in from the left. It will enter the patient and produce a variety of gammas in many directions. And we can place a detector at 90 degrees. And then with a collimation system, we could potentially identify exactly where we are. So the representation on the left is the patient case. On the right, you have the detectors. So you have the protons producing the Bragg peak, and the detectors are acquiring all the signal in different locations. And this is a big advantage, because then you can use the collimation system to give you position, and you can have the intensity of the beam measured by the detectors. Okay, so what is the real problem of prompt gamma, and why is it so difficult to do? It's got to do with the fact that the majority of the signal that your detector picks up is really just background noise. So you need to find a way of removing all this noise. So I've put it here as a simple example of finding a needle in a haystack. Here's an example of a Bragg peak in yellow that's hitting a water fountain. And the system that we want to do is measure the blue lines. The blue lines are your prompt gammas that go straight into your detector, and these are the good signals. But the background signal is made up of all these green lines where the photon can make it out of the detector. So this is something that you have to reject. You can have a situation where the photon also interacts in the collimation system, which is also not good. And you can also have an interaction inside the medium, which hits the primary detector. All these green lines have to be rejected. In addition to that, there's also the room scatter. So the prompt gamma will produce a very large amount of neutrons, and these neutrons activate also the walls. And these emit also a large amount of prompt gammas that have to be rejected. So what you're looking for in this very large signal is the blue lines, which are a very, very small minority of your total signal. So how do we do it? Well, you have two properties that we can use. One of them is timing. So if you have a cyclotron, you have a very fixed pulse. And with that pulse, you can put a little window around it. So here we represent the different gammas that you see at the detector. The blue, again, is the one we want. The green and the red are the ones we want to reject. So if we put a time window around 3 nanoseconds, as you can see, the dark gray 3 nanosecond window, you can focus on the blue and the green, right? And you manage to reject all the neutron background, but you still have to separate the blue from the green. And that you can do based on energy. So now you have an energy selection on the horizontal axis, which is energy, and you can use that information to tell you what's prompt gamma and what is just background gamma. And if we put the two of them together, it's what we measured almost 10 years ago, you get a spectrum that looks like this: time versus energy, and you see these little blobs, which are the ones that tell you the properties of the medium that's sending it. So in the case of oxygen, you see the blob at 6.1, In the case of carbon, you see the blob around 4.4. So this is a very clear indication. If you use these peaks, you can know exactly where everything is coming from. So what about different particles and how do they work for different accelerators, right? So this is the more technical part where I digress through cyclotron systems and synchrotron. So a cyclotron system is a pulse system. It's continuously repeating at a certain frequency. The one from MGH was very unique. It had a 9.4 nanosecond repetition time, and the pulse width was roughly 1 nanosecond. So every 2 pulses was separated by a very fixed time, and the pulse width was very unique, 1 nanosecond. And in every pulse, we would get around 100 protons. Right, so in every bunch, we get around 100 protons. And this was very unique because it allowed us to build a very specific electronics for this whole system. 1 second. So here is the design put on the gantry and MGH. You see primarily all the equipment here. You see the collimation right at the top with a phantom. Then you see all the scintillator, all the electronics running it, and you see a big data acquisition system outside the room for processing all this information. So this is just a standard design of what we did. Okay, so what we did, and in fact, my student did all the work. He did all the measurements. Here we measured the Bragg peak for different energies. So we took those red blobs and we identified every single red blob representing one unique energy. And you can see that, for example, the highest energy, the one which is the highest peak, the dark brown, represents the 6.1 MeV line, and that's the oxygen line. You can also see the 4.4 very clearly, which is the blue line. You can also see the green one, which is the 5.2, which is the double escape peak. And so all of these are very unique situations where you can see for every energy line, you see the representation for the water, for example, and also for the carbon. In the carbon, we don't have the 6.1 because it's carbon, but we do have a very strong 4.4 energy line. Okay, how do we measure now the position of the Bragg peak? Knowing all this energy information, well, we just need 2 measurement points now, 1 point before the end of the Bragg peak and 1 point after. And with these 2 points, then we can interpolate very accurately to a sub-millimeter position exactly where the Bragg peak is. So this simplifies. We don't need a very heavy digital system. We just need 2 very good detectors or scintillators that can give us exactly this information before and after the Bragg peak. This is represented by the vertical red line and the green line. And then to identify the point in the Bragg peak that is the tip, you just calculate the ratio of these curves. So for example, if you calculate the ratio of the brown to the blue curve on the left, you very accurately can identify the Bragg peak to sub-millimeter precision. So we did that, we identified and we introduced shifts. This was a shift of 2.3 millimeters, which was very easy to observe, and we even observed below that. And this was done for a proton beam with an energy of 151 MeV, representing approximately 159 millimeters in range. Okay, so the big change that happened when I moved to Heidelberg was that the lanthanum bromide was not an ideal scintillator because it's naturally radioactive, and so I moved to cerium bromide. Here's a representation from the commercial companies that sell the different background noise that you get from the crystal. And you see the dark blue right at the bottom is the cerium bromide, and it has a factor of 50 less noise. So, and this noise is relevant up to around 3 MeV. So everything from 0 to 3 MeV is highly biased by this natural radioactive system that is lanthanum. Lanthanum is a natural radioactive element. So by moving to cerium bromide, I got rid of all the background in the low energy from 0 to 3 MeV. And that is especially important to carbon ions, not so much to protons. And that's why I moved to cerium bromide. So the design now was customized to the synchrotron, and the synchrotron allowed us different types of particles. We focused on hydrogen and carbon, of course, and most of our targets were made up of water, PMMA, titanium, aluminium. We tried different metal inserts also to check if we could see that clearly. Now, the difference is also the amount of signal that we get. In the case of protons, we are usually shooting around 10 to 9, 10 to 10 particles. In the case of carbon, we're usually shooting 100 times less particles. So this is good from an electronics perspective, but it's also a problem because we have to really know when the beam enters the room. So we have to build a specialized detector, a trigger system. So in the case of the synchrotron, because we don't have a pulsed system, now it's continuous beam, we had to design different types of triggers to tell us when the particles were entering the room. And so the trigger is the light blue plane that you see crossing the beam, the red line. So the trigger is the time that tells you the particle has entered the room. So once the particle enters the room, then we know that is time 0. And from that on, we count the time until it hits the detector. We tried different types of triggers. We tried scintillators, scintillating fibers. We tried a plastic scintillator, and we tried other things. And we found eventually that the scintillating fibers were ideally suited for us. So we ended up designing a small scintillating fiber trigger. Okay, so the big importance of the trigger is to tell you when the particles enter the room. And you see at the bottom, you see this variability in the signal. So this is a continuous beam where the distance and time between each two peaks can change. But we can see the difference in the height of the peak. So on the right, you see sometimes a triple hit where you see 3 peaks, and you see a double hit, which you see 2 peaks, and you even see single hits. This tells us that we have a very good accuracy in the identification of individual particles. So the trigger was working really well. And this was done at the sampling rate of 1 nanosecond. So it was absolutely perfect with the design that we did. This is why we went for the scintillating fibers. So it has a time spectrum of the information that's coming into the room, and you can see the signal. And the signal that we care about is the main red one, which is the prompt gamma. Everything else is background radiation from the neutrons and also from the fast fragments induced gamma. So we had to basically acquire these signals every few nanoseconds, then deconvolve the important signal, which is the prompt gamma component, which is the red one, and reject everything else. And so here's the example of a prompt gamma for carbon versus hydrogen. So the blue is the carbon and the red is the hydrogen. And you'll notice that in the high energy, so where you see 4, 5, and 6 MeV, you see the red is larger than the blue. This is not an indication that hydrogen tends to primarily interact with the elements with the small energy, with high energy release. So for example, 6 MeV with oxygen, 4.4 MeV with the carbon. In the case of the carbon ion beam, the signal tends to be stronger in the low energy. So in the 700 or 0.718 MeV in the low energy, you see now the production of boron. These are all the fragments that are produced when carbon hits elements. They don't just hit by exciting, they hit elements and break them up into different components. So the big difference was that at high energy, we could see the proton beam very well, and at low energy, we had to focus on the carbon beam. In addition to that, we wanted to be able to see implanted metals like titanium, and we could see them very clearly. They produce additional peaks, which are very unique to each metal. So the titanium produced a variety of peaks in the close to 1 MeV range. So you see 4 peaks there. And you see how very clear they appear as significant bumps in the detection system. So we designed a possible application of the system for the HIT facility, and we filed a patent on this design. Yeah, we show that in order to identify the Bragg peak, you would need 2 lines of sight from the detectors represented by yellow, and you have the red as the entrance beam. So with 2 lines of sight, 1 measurement before the Bragg peak and 1 measurement after the Bragg peak, we can very accurately predict where the Bragg peak is. Okay, then the final case is we applied this to prostate cancer, which is a major problem in protons, and we developed a method using the prompt gamma spectroscopy. So in standard proton centers, prostates are usually treated with lateral beams as given by the 90 to 170 degrees. And if you rotate them a little bit, 80 or 280, you still have a very high dose to the rectum. So the rectum is the major concern in the prostate with the lateral beams. So what we thought what would be ideal was to use a rectal balloon to separate the rectum from the prostate and to put into the rectal balloon a certain target that allows to see that the beam has entered into the rectal balloon. So we investigated silicon oxide. And so what we did is in the rectal balloon, we introduced, instead of water, a mix of silicon oxide with water. And it would allow us to identify exactly when the proton beam entered into the rectum, and it told us that we have given too much dose to the rectum. Why the silicon oxide? Because there's a very unique peak at around 1.8 MeV that is characteristic of the silicon. So if we see this peak, we see that the beam has gone into the rectum, and that therefore the rectal wall is suffering from toxicity. So we had a phantom, a brachytherapy phantom that we used for the prostate, in which we inserted the rectal balloon, and you can see the rectal balloon on the right with the prostate represented tied up to it. And we used this prostate phantom to study the impact of the silicon line and how to really manage prostates with prompt gamma. So what we did is we changed the bragg peak a few millimeters by changing the range, and you see that the peak changes of the silicon. So if you pay attention to the two arrows, you see that at 1.8 MeV, you see the peak getting smaller and smaller as you get shallower and shallower. So the shallowest energy is 98 MeV. The deepest energy is 115 MeV. With the deepest energy, you're already in the rectum, which is what you want to avoid. And the shallowest energy, you're not in the rectum, and so you're not producing toxicity. So ideally, with this rectal balloon approach, you can identify where to put the bragg peak without it, and at the same time reduce the toxicity to the rectum. And so with the rectal balloon, and this method allows us to also study for different ability to position the spots very clear. We even published a data set that is available, which provides also data spots so that anyone else can study this with this information. Okay, so the key point with the rectal balloon is that is silicon oxide based, is that you can very accurately track treatment of the prostate with protons or carbon ions, and you can significantly reduce the toxicity to the rectum like this. So just to finish, PGS has been demonstrated for the first time in synchrotron-based HIT facility, which is in Heidelberg. We are developing a prototype for preclinical prompt gamma spectroscopy to be installed at the HIT. We have a patent filed. We were able to resolve single particles within a bunch and measure the time, the microstructure of the beam, which is very important in a continuous beam, such as the synchrotron. And we observe variations in carbon and oxygen concentrations of the target through PGS. And finally, we were able to achieve real-time range monitoring for prostate cancer with our rectal balloon approach based on silicon oxide. This is the people I want to acknowledge, all the people from the HIT and from the DKFZ, especially my postdoc, Paula Martins, who did a lot of the work in conjunction with my former PhD student, Ricardo Dalbello. They were the two drivers in Heidelberg, and they managed to get this working over a period of 3 years. Thank you very much for your attention, and I'm available for questions.
Thank you very much, Professor João Seco. I have one question. I don't know, Professor, and you talked about this in the final of your presentation, but I work with radiobiology, and I want you I want to know more about in terms. Did you simulate radiation effects in different organs related with this new approach concerning the organs that we have behind and surrounding the prostate?
So no, we didn't simulate the radiobiology is always based on RBE models, on LQ models, right? And you have to know an alpha and a beta. And this is not straightforward because the alpha beta changes for organ. So the rectum, the bladder, and the tumor, they all change. So we didn't do any radiation biology studies on the effect. We were just focused on measuring the location of the bragg peak. But by controlling the bragg peak, we technically reduce the toxicity. So in principle, it should be advantageous because we reduce the dose. Thank you very much for the invitation. And
okay, thank you very much, Professor João Seco. So the last part of this afternoon will be the presentations of 3 projects related with medical physics that includes Portuguese and UT Austin teams. So the first project is about automatic treatment planning for proton therapy and will be presented by Professor Joana Dias.
Thank you so much for the invitation to be here. I'm here to talk about a research project that has ended already, but I will try to explain a little bit about what was that project and what were the consequences of this project for us. So the project was named Automatic Treatment Planning for Proton Therapy. It ended more or less 1 year ago. And in this project, I was the principal investigator in Portugal. And from the Austin side, we had the privilege of having Professor Mohan as the principal investigator. And we also have 2 more researchers here in Portugal and 2 more researchers in the US. So this was really a very interdisciplinary research team, because we were also tackling a complex problem. And we thought that the best way of handling this problem was really getting together several people with different academic backgrounds. So what was the core challenge of this project? In the Portuguese side, we have been dealing with the optimization of radiotherapy treatment planning for a while now. So in our team, we have people from medical physics, from mathematics, from operations research, from computer science. And the challenge in this project was to go from photon therapy, that was what we usually work with, to proton therapy. And what we wanted to do was to understand the possibility of making proton therapy treatment planning as automated as possible. So basically try to deal with the trial and error procedure of the treatment planning. So in global terms, we wanted to create a solution that could be faster than the manual procedure, of course, reliable, also scalable, and cost effective. And this is why we joined together this interdisciplinary team with all these different competences. So why is this a very challenging procedure? Why is this a very challenging problem? Actually, nowadays, many advances have been made possible, but yet most of the time, treatments are still planned by a human planner with a lot of trial and error procedure. And proton therapy has some features that makes this procedure even more difficult, namely because of uncertainties. So in the optimization side, we are well aware of how we can deal with uncertainties in many other problems, in many other optimization problems. Proton therapy, because of its specificities, also requires uncertainty to be dealt with in an explicit way. So our main aim was to see if we were going to be able to develop what we call robust mathematical models and algorithms. So basically models and algorithms that deal directly and in a very explicit way with all the uncertainty that exists, so that when we are planning a treatment, we are already taking into account these uncertainties and the impact that these uncertainties can have in terms of the treatment outcome. This makes the problem much harder to solve, both from a mathematical point of view and also from an algorithmic point of view. So, as you all know, one of the main advantages of proton therapy is that we can be very, very precise. So we don't have to worry about exit dose. So we know that we can hit the target. If we hit the target well, then we can spare most of the time all the organs at risk. But the problem from an optimization point of view is that this is in fact correct. So proton therapy is very good if we are really hitting the target. Okay, so if we are placing in a correct manner these bragg peaks, this will be very good because we will have a very high dose in the tumor volume and we will be able to spare all the organs at risk, even those that are very close to this tumor. But when we are dealing with proton therapy, there are a lot of uncertainties that we have to deal with. Some of these uncertainties are more or less the same that we also have to deal with when we talk about photon therapy. But here we have another level of uncertainty, actually because we are talking about such a precise treatment that everything that has to do with uncertainties has a much more highly importance than when we are talking about photon. So we have to consider structures that move, structures that can be in a little bit different position, range uncertainties, and our objective was taking everything into account when dealing with automated treatment planning. This is very important because if the tumor is not really where we thought it would be, then the effect of the treatment will not be the same. And even worse, if we have a tumor that is very close to an organ at risk, and if we don't hit the tumor well, we could be jeopardizing what we want to achieve, that is sparing organs at risk. So from an optimization perspective, it's like if we have a target, but the target is not very well defined because we cannot be really sure where it is. So we have to take into account these uncertainties when we are going to do the treatment plan. So what have we done? We try to consider some of the tools that we use in other optimization problems. And what we did was to create the notion of a structure clone. So what does this mean? Basically, instead of just looking at possible scenarios or just considering to be the best as possible in the worst case scenario, what we did was to look at all the structures of interest that we should consider during treatment planning, and we basically create different versions of these structures. So we basically used the original structure and then shifted these structures several times, considering the 3 possible axes, so that instead of having one structure, for each original structure, we multiply this by 14. So we are basically considering different versions of the same original structure, taking into account that probably the structure will not be always, the volume will not be always in the same place. And because we also have range uncertainties, we also have to account for this. So what is the main disadvantage of this approach? As you can all imagine, the number of structures that we are simultaneously considering when we are optimizing the treatment plan is multiplied by 14. Okay, so instead of dealing with 3, 4, 5, 10 structures, we are multiplying all the original structures by 14. And this is the main disadvantage of this process, but fortunately, we have previously developed an automatic procedure where it is not necessary for the human planner to take into account what is happening in each one of these volumes. So we have developed before an automatic robust fluence mapped optimization approach where this algorithm by itself is able to tune some of the optimization parameters so that the restrictions that we want to be satisfied will be satisfied in a total automated way with no need for the human planner to tune parameters. We have used a model that we usually use also for photons, where basically what we do here is a very simple mathematical model where we penalize using weights and using upper and lower bounds. We penalize all the voxels that are not receiving the dose that we wanted to receive. So this is a complex problem in terms of tuning, because we will have a lower and upper bound weight associated with each structure. So as we are multiplying the number of structures by 14, you can imagine that for a human planner, this would not be possible to consider. It would not be possible to tune all these weights, all these lower and upper bounds. But because this is done in an automatic way, then it is feasible to consider this very enlarged number of volumes of interest. So what we do here to automate this process is to use what we call fuzzy inference systems. So these fuzzy inference systems allow us to define rules in a very easy way. So we can define rules in natural language, and these rules are then translated into mathematical terms. And the rules that we use are as simple as this. If a given structure, if a given volume is not complying with a given constraint, and it's very far from complying with this constraint, then I have to increase the importance of this volume in the optimization procedure very much. On the other hand, if the volume is already complying with those restrictions, then I don't have to do anything regarding this organ, this volume. And if it's almost there, it is not there, but it's almost there, then the changes that I have to do in these parameters are very small. So we were able to define this kind of very simple rules that we can easily understand in natural language, that indeed they are very similar to the reasoning behind what the human planner does in this trial and error procedure. And with these fuzzy invariant systems, we can automate all this tuning procedure. To assess our algorithms, what we did was to assess the algorithms using Monte Carlo simulation. So basically what we did was, for each case that we studied, we considered also the impact of treatment fractionation, because the impact of treatment fractionation should not be left aside of this discussion. And so what we did was to simulate using Monte Carlo simulation, using random number generators, the treatment plan of a given case, as if it was repeated several times, so that we could then have some statistic numbers to understand whether this procedure would make sense or not. Of course, whenever you have uncertainty and you look, for instance, to DVH histograms, you don't have a very tiny line that says what is happening with each volume, because you have uncertainty. So instead of having one line, you have these bands. And basically what we want is to narrow the width of these bands. Okay? And so we compared our procedure with other procedures that did not consider this kind of clones and were more considering, for instance, margins. And we reached the conclusion that we were able to achieve very good plans in terms of complying with those restrictions and being robust. So being within what we wanted in terms of those restrictions, even considering explicitly all the sources of uncertainty. What we have done after the project, actually, this project, I think it was very successful because it was able to build a network between these two teams. Actually, 2 weeks ago, we received here João, that was one of the researchers involved in this project. He was here visiting us. And so I am talking about ongoing work because this was really what happened. The UT Austin project was the beginning of everything, but we have been working together even after the end of the project. Nowadays, what we are doing, we are working also in robust beam-angle optimization. So we have not yet studied the influence of the choices of beams in this notion, in this concept of robust treatment plan, and we are now studying it. In the project, we did not consider explicitly the uncertainty associated also with RBE models, and now we are also integrating in our optimization procedures different models of RBE and to see what is the impact of considering these different models. And we are also looking at the impact of the number of fractions, because it is clear when you simulate the treatments, it is clear that the number of fractions has an important impact in the robustness of the solution. And so this is what we are working nowadays. So for us, what was the importance of having this project? Actually, everything that we have done would not be possible without this program. We don't have proton therapy in Portugal, and this was really an opportunity to work with a leading expert in the field. Being able to work with Professor Mohan is really awesome, and he is really very he's always willing to share his knowledge. So meeting him and be able to work with him is really precious. And for us, we were able to gain an experience and the knowledge that would not be possible working only with Portuguese teams, because we really don't have that clinical experience here in Portugal. And of course, it was very good because, as I said, we are still collaborating, we are still working together even after the project has ended. And I think this is a very good way of showing the success of a project. It didn't end when the project ended, and we are still working, and actually we have made another proposal for funding because we think that this is really something that is worth investigating and continue to work together. And this is all for my part. Thank you so much for your attention.
Thank you, Professor Joana. It's very interesting, your project, and also the possibility to continue the collaboration and to see how important it is grants for us in Portugal, that we don't have some types of technology like the proton therapy and the patients, and it's very important to have this type of raise money. I think we can say like this. I have a question, and it's a curiosity. And when we spoke about different structures and you simulate all the movements and in 3 dimensions, my question is different organs, different movements, because I'm talking about, for example, heart and lung that have movements completely different. My question is, did you have in consideration this kind of physiology in your work?
Yes, basically what we do when we develop what we call these clones, we basically consider what we can call extreme positions of these volumes. Okay, so we don't consider all possible positions or all possible volumes that these structures can take. We consider like extreme positions. And to define these extreme positions, what we did was to consult the literature available. And actually, for most of the volumes, for most of the structures, there are already studies that show what is to be expected in terms of movement. So in terms of the positioning errors, in terms of the systematic errors. And so what we did was that. So for each kind of location of the tumor, we went and reviewed the literature to understand what would make sense, considering the kind of uncertainty that we can have, because as you are saying, different organs in different locations, they vary a lot. So the uncertainties that we have to consider, they vary a lot. Actually, they are even different considering the type of measures that some institutions have to try to diminish the uncertainty associated with these organs. For instance, if we are talking about an abdominal tumor, some of the institutions have this, I'm not an expert on this, so it's like a belt that tries to keep everything together and not being, so things will not move as much as they would if this kind of container would exist.
Okay.
So even these things should be taken into account when planning the treatments.
Okay. Thank you very much, Professor Joana. Okay, so we move for the next project. And the next project is about TOF-PET for proton therapy, and will be presented by Professor Stefaan Tavernier.
So the title is Proton Range Verification for Proton Therapy, and it is one of the projects that is funded by the UT Austin Portugal Program. And I will basically review the motivation of the project. So why do we do what we do, and the status of the project. Now, about the motivation, I will probably say a few things that you already heard before in those lectures, but still let me see it. So that protons, unlike gamma rays, travel until they have lost all their energy and stop. And the maximum dose is delivered at the very end of the proton range, and no dose is delivered beyond. So if you're sure that the beam is where you think it is, it can be extremely precise. And proton radiation therapy is, of course, more expensive than plasma gamma therapy, but so it's mainly used when the area to be radiated is close to some vital organs that we really want to spare. However, there are a few problems, and one problem, I'm sure you heard it again and again, is all this is quite nice if you're sure the proton beam relative to the patient is where you think it is. Now, there are plenty of reasons why that is easier said than done. For one thing, of course, you have to be sure the patient is positioned where you think it is, the organs in the patient can move. All this very important practical consideration play a role, but there is also an even a more fundamental physical problem, because at least in principle, you could make a CT image, put the patient there, make a CT image, irradiate, make again a CT image to be sure he doesn't move. But even that would not solve the problem. And the reason is that what you see in a CT image and the stopping power for protons is not the same thing. In the CT image, it's an X-ray image. And an X-ray image, to first approximation, the stopping power is proportional to the fourth power of the Z, the charge or the nuclei. While the stopping of protons has to be do with the number of electrons, so it's linear with the Z of the tissue you are traveling in. So if you know the stopping power for X-rays, that doesn't mean you know the stopping power for protons. Of course, if you knew 100% exactly the composition of the tissue, you calculate one from the other, but you never know 100% the composition of the tissue for many reasons. Bone can be more or less dense, tissue can contain less water or more water. There is unavoidably some uncertainty. So even if you would solve all the other problems about motion and so on, you would still have the problem that the CT image is not enough to tell you how long the trajectory of the proton is going to be in the tissue. And all these uncertainties make that it is highly desirable to really measure the position of the beam during the irradiation. And this as a check, you have made your treatment plan, you have to do things like that, but then making this measurement would be a way to be more assured that what you're doing is really what you think you're doing. So how could you experimentally determine where the proton beams stop in the tissue, where in space exactly that happens? Now, there are essentially three methods. And one would be prompt gamma rays using a collimator. Another one would be prompt gamma rays as a control camera. And the third one would be positron emission tomography. And I'm sure you all know about what positron emission tomography is about. You could think of other methods, like there are a number of prompt charged particles, there is neutron emission, but to the best of my knowledge, those other methods do not look a priori too promising, and certainly much less effort has gone into that. So our idea and the aim of our project is to study the use of PET in proton range verification. But I would like to start by making a comparison of the different methods that one could use. So the first and probably the simplest method would be to use prompt gamma rays and collimator. Now, when a proton beam travels in tissue, it will undergo nuclear interactions, and in the nuclear interactions, gamma rays are being produced. Here to the right, you see a plot of the spectrum of the emitted gamma rays, and there are some gamma important lines at 4.5. It says to the interaction of the protons with the carbon in the beam. There is another line at 5 MeV, and another one which is to the reaction on oxygen at a bit above 6. So there are fairly high energy gamma rays that are emitted. Now, the fairly high energy in some extent is an advantage because they have a high probability to leave the patient. Now, they are prompt refers to the fact that those gamma rays are emitted within nanosecond of the interaction with the beam. So in the proton beam has a reaction with a nucleus, there is some nuclear reaction, but this is very fast, so fast that we can consider this as instantaneously. So how could you measure those gamma rays? Well, it could be done by something that's shown on the drawing on the left to the bottom. So you use a collimator. A collimator, that's a heavy piece of metal. It can be lead. But if you're a bit richer, you can use tungsten, which is better but more expensive. And you make a very thin slit. And basically, the gamma rays that are emitted, and behind that slit, you have a detector for gamma rays. So that's a standard technique how to detect and localize gamma rays of this energy. And so from this, you have the beam, and then you put this in a geometry as in this figure, and you have an image of where the beam stops, or rather where those prom gammas are emitted. Now, you see immediately a good point and a difficulty in this approach. The good point, of course, it's fairly simple. It's not complicated. The weak point is that, of course, this split has to be very thin. And if you have a wide split, of course, you lose completely your precision. So because the split is very thin, the probability that one of the gammas that's emitted goes to that split and is detected is quite small. So only a very small fraction of the prom gammas is detected, and that means that your sensitivity is less. I mean, you need to have measured for during more protons to have enough precision. Now there is now this method, as far as I know, is available commercially. So it's a picture I took from EBA, as you may know, is one of the proton radiation producers, and I think they sell a system like that commercially. Now it's possible to do something else that also uses prom gammas, and that is, why is not okay. Okay. Yes, okay, sorry. And that is to use the prom gammas as a Proton, as a Compton camera. So the idea is the following. So you have the same case, you have a patient and there is a beam, and gammas, these prom gammas are emitted. But instead of a collimator, you use two detectors. One detector, the detector to the right, what I call the high Z detector, is a very similar detector as in the case of the use of a collimator. So it's scintillating crystals, and you basically make enough scintillating material that you completely stop the gamma and measure its energy and position. But you have a second, instead of a collimator, you have another detector, which I call the low Z detector. That's a detector that is made, as the name says, of low Z material, and the gamma ray has a large probability to undergo a Compton interaction in there and be deviated. Now, the thickness of this detector should be such that you have enough probability for a gamma to do a Compton scattering, but not so thick that you have a big probability that there are more than one Compton scatter in it. Now the interesting thing is that if you know and measure the energy deposited in the low Z detector and the energy deposited and the position in the high Z detector, you know the angle between the arrival of the gamma and the trajectory of the gamma between the two detectors. That means that if you have measured the interaction in the two detectors, you know that the gamma came somewhere from a cone, from all the gammas, potential directions from the gammas that would have the given angle that you know of. Now you say, okay, well, that's nice, but that doesn't tell you where it came from. Well, if you have only one gamma, of course, it doesn't tell you where it came from. But if you have a large number of gamma interactions, there exist mathematical algorithms that will reconstruct the distribution of the origin of the gammas from this collection of events. You see immediately the drawbacks and the advantages. So the obvious advantage is that here you can have a much larger solid angle. You can even cover a relatively large area around the patient using this. But the drawback is this is, of course, much more complicated to do than the simple collimator approach. So, hold on, this is a bit annoying. This is going a bit faster than I planned it to go. Okay, good. Now let's look at what you do when you use PET. So when the proton beam travels in the patient, it has a number of nuclear interactions that produce prom gammas, but those nuclear interactions also produce positron emitters. There are a larger number of reactions, actually. The most important one, for practical purpose, are the production of carbon-11, which is a positron emitter with a decay time of 20 in half-life, 20 minutes, and oxygen 15 with 20 minutes decay time. So if you have a PET detector that you bring around the patient, you can observe those positron emitters, and in this way also observe the proton beam. Now, you probably all know enough about PET to know that you should surround the patient with something that's more or less a ring. However, with modern PET detectors with good timing, it's not mandatory that it's really a full ring. Of course, the closer you are to a full ring, the better. But if you have you should certainly have two detectors on both sides of the patient and sort of preferably not too far away from a ring. But a real ring is essentially impossible because you have to make room for the beam and so on. So basically, it will be a ring with gaps, but that's perfectly possible to do. Now, all these methods have one important problem, let's call it, in common, and that is that what you measure is not the endpoint of the beam. The protons travel in the patient and they undergo nuclear interaction, but if the energy of that proton is too low, the cross-section for that interaction goes to zero. So what you observe will not be the true endpoint of the beam, but will be somewhat before the beam really stops. And that offset is of the order of 5 millimeter, and of course you must include that in your analysis, otherwise you're completely wrong. So let's go a bit more in detail of what would be an advantage of PET. Now, depend if you compare to the simple prompt gammas with a collimator or with the gamma, but the PET will have, it is possible to have a relatively large angle coverage around the patient. PET is a well-established technique. It's not like the prompt gammas, where it's still much less known. So you're using a very well-known technique. PET allows a fairly good spatial resolution. Something like 1 millimeter full width half maximum is feasible if the PET detectors are not too far away. If they are far away, maybe a bit less, but that's something that's quite doable. Another thing is that PET, of course, has more information than the prompt gammas. In principle, I'm not sure it's realistic, but in principle, you could make the tumor itself visible on the same PET image where you see the beam and the tumor Again, I don't pretend that this is realistically doable in a clinical setting, but in principle, that's certainly possible. It is also fairly easy to have markers on the body of the patient. You can very easily have small radioactive sources you put on the body of the patient, and they will be visible on the PET image. So you will see the markers in the body of the patient in the same image as where you see the beam. So it has a number of advantages. Of course, there are some drawbacks too. So PET will certainly be more sensitive to background from the proton beam while the beam is on. We don't know for sure yet if it would be possible to observe the PET image while the beam is on, but for sure that's going to be much more difficult. And you will suffer from more background, certainly compared to the collimator solution. I think the solution from gammas with control scattering will even be more sensitive, will be even worse. Now, this problem of the beam is not necessarily a killer, because depending on the protons accelerator that you have, very often there are, anyway, the beam is not continuous. There are gaps when there is no beam, so you could take the data during those gaps, and then you could probably include some gaps even if they are not absolutely necessary. So this is not an impossible problem. Another thing that one has to be aware of is that the PET image must be made immediately after the beam. The prompt gamma, they are prompt, so they are immediate. But the PET image, because of the decay time of the PET, for example, carbon-11, you must be sure that you're not imaging that PET traces that were produced 20 minutes ago, because those activity may move with time. So that's something to bear in mind, and be sure you take that into account in your analysis. So after this introduction to why we decided to look into the use of PET, let's come to the project that was funded thanks to the UT Austin Portugal Program. So you see here the title of the project and the team that's involved. Now, the aim of the project was to build a prototype PET system to evaluate PET in proton therapy. The aim was to make tests at the proton facility at MD Anderson using phantoms and compare that with simulation. Let me stress that this was never the intention to build a device that could really be used as a clinical device. That would be require resources way beyond what was available in the project, but it is a necessary first step. You have to build something that's realistic, that's built the way something that could be used in clinical settings should look like, and test it and study it carefully, and then have a clear view of what the difficulties and the problems is you may encounter, and then have a better assessment if that's really something you really want to build, and build a clinical system, which is a big effort and a big investment, or not. So that's basically what the aim was to do. And at present, the situation is that the detector is built. So this is a picture to the left is showing how the detector will be at UT Austin. Now, the detector here is it's a bit more than a quarter of a ring facing each other. And it was designed to be usable in principle as a device to aid in proton irradiation in the brain. So detectors are very large and relatively close to the brain, and if there would be a patient, he would be positioned as you see there. Now, in real use with patient, the beam, of course, can become from many directions. and you could orient the beam. So in this picture, you assume the beams come from above. But when you have patients, you have to foresee that the beam can come from any directions. But because we do not plan to do any irradiation with patients, that's not necessary. So our two detectors are just fixed, and we will use it with the beam from coming above, and there will be phantoms, and we will study what we will see. The detectors exist and are built. So to the right, you see the, to the right, you see the detector themselves. So the principle of this detector is to use scintillating crystals and silicon PM arrays, which are photodetectors. So you detect the light produced in the scintillator with this photodetector. So this is a perfectly standard technique in PET scanners. That's all existing PET scanners nowadays use them. Well, not all of them, but most of them use some sort of variant of this principle. And to the left, you see this assembled in the detectors that are built. So as of today, the PET detector is completely finished. You see it here, the fully assembled detector. So you see the two quarters of a detector on top. Below is electronics to read out the thing. And what you see there in the middle is a line source, germanium-68 line source that you can mechanically move and test the detectors. And that's basically where we are now in the project. We are testing the detectors and making sure they work as they are planned to work. So that's basically the case. So we do the main things that you look at. You look at the time resolution, that image resolution, and that constructed images. So those characteristics are as they were planned. So the time resolution for a full scanner is shown here. So the coincidence time resolution full width maximum is 229 picosecond. Which was about as good as the present technology as of PET allows. This is an example of the signal recorded of one of the detectors when the detectors are irradiated with a sodium 22 source. So sodium 22 is a positron emitter. So the positron are emitted, they produce two gamma rays. So basically what comes out of your source are gamma rays of 511 keV. So as you would have in a real PET scanner, it produces also 1200 keV gamma rays. So you see those two peaks, the 511 and 1200. Now you may notice that the scale doesn't seem to be linear, right? So 511 and 1200, that's not to scale. Now that is a known characteristics of this type of detector and has to do with the saturation in the signal that the photodetector, the silicon PM array, has. That's a known effect, and we also know how to deal with it and how to correct for it. But here these are the raw data uncorrected. Now you also see Compton scatter events. Gamma ray entering the detector doesn't necessarily posit all its energy. You can also have a Compton and then you see those bands, which are the Compton. So all this is perfectly normal and what we should see and what we indeed see. Another measurement is the energy resolution. Now the energy resolution, the directly measured energy resolution is a bit more than 6%. Now, some people are familiar with PET will say, hey, that cannot be true. Indeed, that cannot be true. The reason is that this is uncorrected for the nonlinear effect of the silicon PM. It has no response. You can correct for that, and we know how to do that. And the true energy resolution after you have corrected for this nonlinearity is more like 12%. And that is what it should be. And again, it's perfectly okay. And we also started to make the first image reconstructions on it. Now, in parallel with this construction, this basically hardware work, building a detector, we have been developing simulations of this production of positrons. I think you've understood from the beginning that in order to use whatever measurements you do with a system like that to translate that in real position of the beam in the patient, you will have to have a well-studied and reliable simulation. So that also is something we have developed, and I just show you one or two images to convince you that we have that. So this is a comparison of what happens when you shoot a proton beam in PMMA phantom. Now, PMMA is kind of plastic that is sort of similar to human tissue, and it's often used for this sort of tests. So in this image, what you had a piece of PMMA which was larger than 10 centimeter, and so you shoot the beam on that from the left, and of course when the beam did not enter the PMMA, no positron emitters are produced. You're in air, and you are in the PMMA, you produce positron emitters, and towards the end of the beam, the number of positrons per unit length you produce increases, and then where the energy of the proton becomes too low, it drops to zero, and you have a curve like this. So what you see here is the measurement value, and which are the red points, and the simulation, which is the plot that's on top of it, and you see we managed to quite well reproduce what is measured and what we simulate. The second plot shows you the same thing. It's PMMA and the proton beam entering in this PMMA, but it also shows the dose deposition calculated from the same thing. Now, the dose deposition is really connected to the beam. The dose is really maximum at the end of the beam, and it really drops to zero exactly where the beam stops. Here you see what I've mentioned before, that the end of the beam, as you measure it using the positrons, and the true end of the beam, there is a difference which depends on the tissue, of course, depending on the tissue and so on. The difference will be, but it's something of the order of 5 millimeters, something you have to take into account. Now, this is exactly the same problem if you use proton gammas or positrons. There is no particular advantage of one of the two relative to the other. So in summary, then, we have a number of reasons to think that PET could be a better way than proton gammas to monitor the proton beam. In this project, we have built a realistic PET system for this application, and it will be tested at MD Anderson beam later this year. Now, later this year is mainly because for a reason of the program, I don't know what, but MD Anderson, the beam is not available now. Otherwise, we would, the detectors are ready to do that. But we'll have to wait until the beam is again available for this sort of plans to really do the beam tests. And that is about what I wanted to tell you, and I thank you for your attention. And of course, if you have any questions, please go ahead and ask.
I have one, Professor. The project is finishing, right? And in your opinion, you chose the head and neck cancer to test. Did you already did some tests with this type of cancer? Did you plan to do it? How is your expectation?
No, I repeat, we do not plan to do any tests with patients. This is a purely technical project, and the aim is to study. Now, we could maybe use the same detector in a later phase of the project with patients, because the detector is designed in such a way that it could be used for that. But this is not part of the project because we believe that it is really would be trying to go too fast, and it's really we want. For me, the conclusion will be after this. Well, we now understand the problems that you will have better, and we still think, after all, that this is the good way to go, and we should proceed. Or maybe we say, well, we discover some problems that are maybe more difficult than we thought, and maybe feel less sure. That for me, I have no prejudice what the outcome will be. Although I tend to think that the problem answer will probably be that is worth continuing. I'm not sort of being pessimistic about it, but let's do things step by step. Let's do this test and study things carefully in all ways, and then think, well, that's the right way to go, or maybe it's not the right way to go.
Okay, thank you very much. If there is no questions, we can move to the third and the last project. This project will be presented by Professor Célia Fernandes, and the title is Theranostic Strategy for Proton Boron Capture Therapy of Pancreatic Cancer.
Good afternoon, everybody. It has been a very nice session during this afternoon. And today I will present our project, Theranostic Strategy for Proton Boron Capture Therapy of Pancreatic Cancer. And this is a project between the MD Anderson Cancer Center in Houston, namely the Department of Cancer Systems Imaging and the Proton Therapy Center, of course, and here in Portugal, in Lisbon, the CTTN Institute and our group, the Radiopharmaceutical Sciences Group. In Houston, we work with Professor Shun Lee mainly, and also with Professor Narayan, that was an amazing person to our project. So, what is the main goal of our project? The main goal of our project is to obtain experimental evidence that PBCT can lead to an increased biological response of ductal pancreatic cells accumulating boronated micelles and treated with a clinical proton beam in a dose-dependent manner and proportionally to the cellular concentration of boron 11. So we intend to administer the micelles with boron 11. They should go to the tumor, irradiate with protons, and have the alpha particles to do the treatment. Moreover, we want also to have a theranostic strategy relying on the use of the isostructural rhenium and 99 MTC complexes with the ligand selected containing boron to obtain boronated micelles and taking advantage of the SPECT imaging properties of 99 MTC. So, as we have seen today, proton therapy is emerging as one of the most attractive radiotherapeutic strategies to treat different types of cancer. However, as we've seen today, there are still some concerns about and some difficulties, and there are always room to improve. Moreover, heavy ions are expected to provide better therapeutic response due to their high lead, leading to complex DNA lesions and more efficient cell killing. However, there are some constraints to his use. So what is the rationale? One possible alternative to enhance the radiobiological effectiveness in proton therapy is based on the irradiation of boron 11, forming 3 alpha particles with high lead, as you can see in the scheme below. Alpha particles have higher lead and higher RBE than protons, and the irradiated tumor cells accumulating boron compounds could suffer an enhanced cell death when compared with the cells irradiated solely with protons without the importance of having here the boron compounds. So this is a strategy similar to the BNCT. However, it has some advantages compared to BNCT. And why? Because in the case of PBCT, we have a nuclear reaction with boron 11 that is around four times more abundant than boron 10 used in the BNCT. Moreover, it has also to be with the cross-section of this reaction. This is higher, reaching high values for incident protons of low energy around the Bragg peak regions. What does it mean? It means that alpha particles in healthy tissues surrounding the tumor is expected to be rather low, and maybe they are more not so heavily treated. So in the case of BNCT, we can activate the boron 10 nuclei in the non-target trajectory of the target tumor and form the alpha particles. So the first experimental validation of PBCT was reported very, very recently by João and collaborators based on the proton irradiation of prostate cancer cells with non-tumorigenic breast epithelial cells previously treated with boracaptate here in the image. So they have seen that, in fact, the cells irradiated with 62 MIVs or 250 clinical protons spread out Bragg peaks, and the results show that the presence of the boron nuclei increases the radiobiological effectiveness of the proton beams based on clonogenic assays and gamma-2 ACEs assays. However, it is crucial to further validate these experimental results and shed more light in the relevance of PBCT to improve proton therapy efficacy. Moreover, recently, some results from Gabriel Sawaguchi contradict the results from João. And so, what is really our challenge? To explore the delivery of micelles to the radio-resistant pancreatic cancer cells. And for this, we intend to encapsulate the drug in polymers that self-assembly in water, and the boron, the rhenium, the complex boronated with rhenium are encapsulated in the micelles, and we can do it also with the 99 MTC analogous complexes for the theranostic strategy that I have spoken. So these are the complexes that our group in Lisbon have already synthesized several years and studied several years ago, and we thought that the presence of the boron, one boron atom per molecule, and could be used for this type of studies. So these are the complexes that we have selected, and as platforms for drug delivery, we have selected branched micelles developed by the group of Professor Shun Lee that were already demonstrated that they can go and deliver the drugs to the pancreatic tumor cells. So in this case, we have, as we can see in this slide, we have small and lipophilic complexes, neutral and very, very stable complexes that are good indication to be efficiently incorporated in these micelles developed by Professor Lee in the MDA Anderson. So this is the tasks of our project. We start with the synthesis of the polymeric micelles carrying the boronated complexes and evaluation of the cytotoxicity and cellular uptake in pancreatic cancer cells, and then do the irradiation experiments with protons in the proton cancer center in Houston. We also intend to perform microspec imaging and biodistribution studies in order to see if the B cells radiolabeled encapsulating the 99 MTC complexes are able to reach or not the tumors. So we started with the synthesis of the complexes that have been done by my colleague Elisa Palma, and she has synthesized these two complexes. The single one was more difficult to obtain, so she started with these two complexes, were obtained in very high yield, and they were characterized by infrared spectroscopy and by NMR. I will not enter in details into this, but I can, you may see that they are in agreement with the structure of the complex. We have also analyzed them by HPLC, and we have one single peak for these complexes. They are very in high purity. And then we have synthesized the polymer, the copolymer, the branched copolymer, to prepare the micelles. And this was done by the group of Professor Chun Li, by Gudong, and he has synthesized these polymers and characterized them, and then they have been used. We have sent for the EMDI the rhenium complexes, the boronated rhenium complex, and they have prepared the micelles with the complex incorporated. So the ligands, the complex and the polymer were dissolved in organic solvents, and then with water, when they are present in the water, they self-assembly and they encapsulate the rhenium complexes. They were successfully encapsulated for this complex, but for the three-substituted complex, the other one, there was problems and we were not able to encapsulate it. Moreover, we have also encapsulated and prepared other type of micelles with other boronated compounds to use for comparison. So then we have decided, of course, if we prepare micelles, we have to characterize them. And here we have the characterization with a very good polydispersivity index with 0.1, which indicates that they are very homogeneous, and with the effective diameter of 74 nanometers in this case. And we were able to determine the entropic efficiency that was relatively high, with higher than 80% for the rhenium complex. And also we have determined the drug loading content by ICP-MS. And then we decided to do the cellular uptake studies in order to know if when the compounds are incubated with MAIAPAC2 cells that are from pancreatic cancer, if they are able to internalize, if our compounds are able to internalize in this type of micelles. And so we have done it for the complex with for the micelles. M is from micelles in two different concentrations, 0.2 millimolar and 0.1 millimolar, and we have determined the concentration in nanograms of boron and nanograms of rhenium. Be aware, and pay attention because, in fact, the ratio between rhenium and boron is around 18 because the boron is very, the rhenium is much more heavy. And so, anyway, it is a little, the ratio inside the cells is a little bit higher than the theoretical one. But in any case, we were able to find boron and rhenium internalized in the or associated with the cells. We have done the same for the other B cells. In this case, we don't have rhenium, we only have boron, and the amount of boron is really very high. So then we have decided to continue the work, planning the irradiation with protons. What was in the plan was to prepare a radiation setup and dosimetry assessment at the Proton Center in the MD Anderson, and also irradiate cells incubated with the boronated mist cells, and use different doses and determine the effects on cell viability and cell survival, and also do studies about the evaluation of the DNA damage. For this, we went, Felipe Mendes and from our team in Portugal and me, we went to the Proton Center in Houston, and we have the help, the total support of Professor Narayan. He is really amazing. He is very kind and always available to help and to do all this job at Saturdays, because it's not possible to do it during the week, because it works between the 6 a.m. to 24 p.m. I think. So all the work has to be done in Saturdays, in the weekends. So we went there, but we don't know nothing about proton irradiation and dosimetry and nothing about this. So everything was done by Professor Narayan. And here we have some images where we have been irradiating our cells after incubation with our boronated compounds. So this is the plan, the protocol that we have done. We have MIAPAC2 cells incubated for 6 hours with the compounds. We have used the BPA, it's a boron compound, as a reference. This BPA has also only 1 boron per molecule, and we have tested 2 different concentrations, 40 ppm and 80 ppm of boron 11. This is ppms of boron 11, and also the B cells prepared with the boron compound or with the rhenium boron complex, boron rhenium complex. And then we have irradiated with 5 grays at low lead in the entrance and in the distal end at high lead. So this is the plan, and we have here the conditions and the cells that we are putting here to irradiate after all the measurements that Professor Narayana have done to ascertain the dose. So, and here are the results that we have obtained for the viability. This is the control media, and what we can see is that our complexes with boronoid iridium compounds are too cytotoxic, because even without irradiation, they don't have viable cells. The BPA at 40 ppm or 80 ppm, it seems not to be the viability seems not to be affected by the irradiation. And the other micelles with the boronated compounds seems to have a slightly effect, but this is very not significant. Then we have done also another irradiation to process the clonogenic assay, and we have used 6 well plates, the same 6 hours of incubation, and also the MIAPAC2 cells. And what we can see is that in our boronated rhenium complexes, we don't have cells, we don't have colonies of cells, because they are too toxic by themselves at this concentration. So it's important to study the best concentrations to be used, or decide to use other complexes. This is something that we need to study in more detail, because really we don't have any colonies here. In the case of the boronate BPA and the micelles with the boronated compound, I only have these photos because this has finished yesterday. So these results are under analysis. It's necessary to count all the colonies and to try to have to do quantifications, but it's an ongoing work. So another thing that was a part of our project is to prepare the radioactive analogous micelles encapsulating the technetium-99 MTC complexes. After all, in this case, we don't have problems of cytotoxicity, because the concentrations are really very low. But this, we have already labeled the complex. So we have prepared the analogous 99 MTC complexes, but we have not yet tested the incorporation of these complexes in the micelles. This is something that is ongoing to do, but we plan to do it, to do the biodistribution and imaging studies with these labeled micelles. We want to do the labeling only with the 99 MTC complex, and eventually a mixture of rhenium and 99 MTC, depending on the concentration that we are able to use of these complexes, since we are facing some problems of cytotoxicity. Okay, so these animal studies will allow them to image the tumor accumulation of the boronated micelles, giving some information about the possibility to do the drug delivery to the pancreatic cancer cells. So by now we have really prepared micelles loaded with the boronated rhenium B2 complexes, and also with the other boronated compounds. And we have performed cellular uptake studies, and we were able to find the boron and rhenium content by ICP-MS in the cells. We were able to do the setup of the irradiation and the dosimetry assessment by Professor Narayan, and we have done this very, very preliminary proton irradiation of pancreatic cells, incubated with the boronated micelles and irradiated at with 5 grays in different positions, entrance and end, and at the end, so low LET, high LET, and we are studying the effects on the cell viability, survival, and evaluation of the DNA damages that we have also performed these studies. I haven't presented them here because I don't have results to show. And what I can say is that this is a work in progress. The project will finish in the end of June in Portugal, but it will continue in the MDA Cancer Center because it has started almost 1 year later there than here. This is something, a problem that arrives. Anyway, as other persons mentioned, we will continue to collaborate, and a partnership has grown here, and this was really like something very interesting and very important to continue this work, because it's something that should be tested. And we also want to explore these micelles for image-guided drug delivery, and also testing boronated micelles for BNCT, eventually depending on the studies of the cytotoxicity. So, and this is the team that have done this work. This is Dr. Antonio Paulo, the PI of the project. I am the shorter one here, of course. And my colleague Elisa have done the synthesis, is here, and Dr. Fernanda Marques and Filipa and Lourdes Gano. They are from the Portuguese team, and here are the team from the MDA Anderson Cancer Center in this, and me and Filipa were there because we have the opportunity to join them in their workshop of the department, and they were so kind that they invited us to participate also. And this is in Galveston, near the beach, so we've been there also 2 days, hearing their presentations, knowing what they are doing and what they are planning to do. It was really scientifically very interesting. This is Professor Shun Lee, this is Zudong, who have helped us a lot also in Saturdays to go with us, because we were not allowed to go alone and to do so he was always working with us. And this is Chi and other colleagues that helped us a lot. And a very, very special, how you say, I am really very, very grateful to Professor Narayan Su, because he was really very, very important. Without him, nothing of this would be done. So, thank you. And for all of you, thank you for your attention.
Thank you very much, Professor Célia. I have one question. I was wondering what was the method to evaluate the cell viability? You presented the results, and it's a curiosity only to know about this method.
I am from radiochemistry. I'm not a biologist. The biologist is Filipa Mendes, okay. But anyway, we have done it by the FTS assay. So we have first incubated the cells, and then we irradiated, and then it was they were, after changing the medium, they stay. I don't remember anymore if it was 48 hours or 72, and then it was the MTS assay I think it was not the MTT. I think it was the MTS.
Okay. And you evaluated 48 hours. It was the other question.
Yes.
Okay.
Yes.
Okay.
And
Okay.
okay, the results probably you have used too much. The concentration of our rhenium complexes was too high because since we only have one boron atom per molecule, when we encapsulate it, we need to have this concentration of boron 11. We have gone to a very high concentration. I think it was 10 millimolar of complexes, and it is really too high. So this was the first experiment, and it must be adjusted, the concentration, of course.
Okay. Thank you very much. I don't know if there's something you want to ask a question. No?
No.
So this is our last presentation of today and of the course. So first I want to say thank you to the presenters and to say thank you to the audience for these long weeks. And it was a pleasure for me to be in the coordination. And now I will give the word to Professor Filomeno, which is the coordinator of the course, to give the last words.
Thank you, Margarida. Thank you, all of you, to stay here. It was a big course with a few weeks. And I think that the objective was done because we made a journey through the image methods, going from basics, physical basics, to clinical applications of the methods presented. I want to say thanks to all of the participants. Thank you all. Thank you to UT Austin for make this collaboration again. And thank you, Vera and Mara.
Thank you.
And all of you. And I think that it was good. It was nice to have you here, all of you.
Thank you, Professor. Thank you.